Good morning, everyone, and welcome to the 27th meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria on Shaping the Future, Input into the Next National Action Plan for Combating Antibiotic-Resistant Bacteria. My name is Sarah McClellan, and I am the designated federal officer for this advisory council. I would like to thank all our attendees and stakeholders for joining us today, including those who provided written public comments. The goal of this advisory council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our country. To accomplish that mission, the advisory council. Sorry, I had a minor technical difficulties. To accomplish that mission, the Advisory Council strives to address the issues related to antibiotic resistance through a One Health approach, which recognizes the deep interconnection between people, animals, plants, and their shared environment, and is evident in all of our proceedings and products. Before we start, there are a few things you should know. This meeting is being recorded and will be available on our website at hhs.gov/PACCARB. Regarding the conflict of interest rules, all 13 voting members of the council are considered special government employees or SGEs and are subject to conflict of interest laws and regulations. The 13 regular government employee members or RGEs representing different agencies and departments on the council have also been vetted for any conflicts of interest. We have received public comment from the following: AMR Strategic Coalition, Sepsis Alliance, Infex Therapeutics, Mitchell Berger, the American Dental Association, Cabrina Miller, Samantha Gasson, Haley Pritchard, Priya Nori, Michael Malia, the Infectious Disease Society of America, Medicine Sans Frontieres, Ronald Devine, Molly Paris, Emma Sherman, and John Sinote. All public comments submitted to the carb@hhs.gov mailbox as of June 14th have been provided to the Council and the Federal Task Force on Combating Antibiotic-Resistant Bacteria. Comments submitted from June 14th onward will be shared once the public comment period closes on June 19th. Lastly, I would like to thank our Deloitte colleagues, Ms. Lauren Plain and Dr. Corey Meyer, for their efforts to support the Council in the planning and execution of this meeting. I will now go through roll call for all Council members. Please let us know if you are present by stating here. For alternate RGEs, please identify yourself and provide the name of the principal you are representing today. Beginning with our voting members, our Chair, Dr. Paul Plummer.
Here.
Our Vice Chair, Dr. Jason Newland.
Here.
Dr. Stephanie Black. Dr. Black, are you with us? Dr. Claire Burbick.
Here.
Dr. Virginia Fate. Dr. Susan Wong.
Here.
Dr. Jenny Kwan.
Here.
Dr. Lynn Marks.
Here.
Dr. Payal Patel.
Here.
Dr. Robin Patel.
Here.
Dr. Joni Sheftel.
Here.
Great, thanks, Joni. Dr. Julia Simzak.
Here.
And Dr. Thomas Whittam.
Here.
Moving to our liaison members, Dr. Allison Robertson for the American Association of Extension Veterinarians.
Yeah.
Welcome. For the American Society of Microbiology, Dr. Jacinda Abdul Mutakabir.
Here.
For the American Veterinary Medical Association, Dr. Mark Papich.
Here.
For the AMR Action Fund, Dr. Henry Skinner.
Here.
For the Bill and Melinda Gates Foundation, Dr. Padmini Srikantaya.
Here.
For EpiX Analytics, Dr. Francisco Zagmet.
Here.
For the International Society of Antimicrobial Chemotherapy, Dr. David Jenkins.
Here.
And for the National Institute for Animal Agriculture, Dr. Lucas Pantaleon.
Here.
Welcome. Now for our regular government employees, or RGEs. Please be sure to indicate if you are covering for the principal RGE. For the U.S. Department of Agriculture, Dr. Roxanne Matroni.
Here.
Dr. Chelsea Shively.
Here.
And Dr. Gamola Fortenberry.
Here.
For the U.S. Department of War, Dr. Paige Waterman.
Here.
And for the Department of Health and Human Services, the Administration for Strategic Preparedness and Response, Dr. Christopher Houchins.
This is Mark Albrecht on behalf of Dr. Chris Houchins.
Welcome, Mark. For the Agency for Research, Healthcare, and Quality, Dr. Melissa Miller.
I'm here.
For the Centers for Disease Control and Prevention, Mr. Michael Craig.
Here.
For the Centers for Medicare and Medicaid Services, Dr. Sherry Ling. For the National Institutes of Health, Dr. Sam Perdue.
Here.
For the Office of the Assistant Secretary for Health, Dr. Tammy Huizinga.
Here.
Welcome. For the Office of Global Affairs, Ms. Angela Monahan.
Here.
For the U.S. Food and Drug Administration, Dr. William Flynn.
Here.
And for the Environmental Protection Agency, Dr. Jay Garland.
Here.
Great. Before we begin, just a few more housekeeping items to remember.
Yeah, sorry to interrupt, but Stephanie Black is unable to unmute. So she responded, but couldn't be heard.
Great, thank you so much. We'll note her attendance. So before we begin, a few housekeeping items. I ask that council members who wish to ask a question or who have a comment to use the raise hand function within Zoom. This can be found by clicking the React button. The moderator for each discussion session will call on you in the order the hands were raised. Once you have been called on, please remember to unmute before speaking and then mute yourself following your comment. Now I'd like to turn it over to PACCARB's Chair, Paul Plummer, and Vice Chair, Jason Newland, to share their welcoming remarks and an overview of this meeting.
Thank you, Sarah, and the entire staff team. We appreciate your work behind the scenes in getting us started this morning. I want to wish a good morning and thank you to everyone that's joining us for this public meeting of PACCARB. It is indeed a real privilege to open today's discussion in a public forum. Public meetings like this matter because they strengthen transparency, invite broader engagement, and help ensure the work of our federal government is informed by technical expertise and the perspectives of those affected by antimicrobial resistance every day. Antimicrobial resistance is not a distant or abstract issue. It affects whether common infections remain treatable, whether routine surgeries and healthcare stay safe, and whether patients, families, clinicians, veterinarians, producers, and communities can continue to rely on the antimicrobial tools we have long taken for granted to keep our communities, companion animals, and food systems safe. This is a timely moment to be discussing this issue. Resistance continues to evolve and spread, and the challenges are changing across human health, animal health, food systems, and the environment. At the same time, advances in research and technology will provide new ways to prevent, track, and respond. For these reasons, the National Action Plan for Combating Antibiotic-Resistant Bacteria must also evolve. As a council, today we have an important responsibility to help ensure the National Action Plan for combating antibiotic-resistant bacteria remains practical, forward-looking, and grounded in the best available science. We have a very full agenda today, and we will get the most value from today if we stay focused on the topics before us and use our time to surface clear, actionable insights. With that, I'm pleased to turn it over to our Vice Chair, Dr. Jason Newland, to say a few words about the importance of this update and what we hope to accomplish today. Jason?
Thank you, Paul. Thank you, everyone that's made us getting back together possible. As Paul said, this is essential for us. I, as a pediatric infectious diseases physician, get to talk about resistance all the time, which makes our national action plan, for me, that much more important. And I know for all of us on this council, we look forward to this discussion and how important it is. Updating this plan is not simply a procedural exercise. Please remember that. It is how we make sure that our country's strategy and implementation of this strategy keeps pace with the emerging and expanding resistance patterns, new evidence, scientific evidence, and lessons that we have learned from implementation and that we will continue to learn. We need this plan, this action plan, to reflect where the risks are increasing, where current approaches are working, and new approaches are needed, and where strong coordination is needed across all sectors. I would say one of the beauties of our council is the One Health approach, this One Health context, how it is impactful across places, people, animals, plants, has been one of the greatest experiences for me in learning more about how resistance impacts so many in many different ways. So as Paul said, as we move through this agenda, we encourage you all to stay very focused on the questions tied to this National Action Plan update. You all are expert, you all are brilliant, you all will make sure that we have a productive discussion that produces recommendations that are clear, they are usable, and they are impactful. So I want to thank everyone for your time and expertise. I want to thank the public for their comments, and I'm really, really excited for the next couple hours that we get to spend together. Paul, back to you.
Thank you, Jason. It's now my privilege to introduce Admiral Brian Christine, the 18th Assistant Secretary for Health at the U.S. Department of Health and Human Services. In this role, he helps lead the nation's public health priorities and also leads the U.S. Public Health Service Commission Corps, one of the nation's 8 uniformed services. As Assistant Secretary for Health, he has emphasized priorities including restoring trust in public health, promoting transparency, and strengthening the nation's health. We are grateful to have him with us today, particularly as this council discusses antimicrobial resistance and the importance of keeping our national response current, science-based, and action-oriented. Admiral Christine, thank you for joining us. The floor is yours.
Oh, thank you, Dr. Plummer. Excuse me. Thank you, Dr. Plummer. Thanks for that kind introduction. It's great to be here with you all today. I'm very excited to join you. I want to thank the members of the PACCARB for your continued leadership and your commitment to addressing what really is one of the most pressing public health challenges of our time. And you heard Dr. Plummer mention transparency and restoring trust in healthcare entities, because that's very much important to me. And I think things like this advisory council are incredibly important to doing that, restoring trust. And as we do it, we always want to do things, like I said, with complete transparency. So I appreciate what you all are doing. As we work to advance the administration's vision to make America healthy again, combating antimicrobial resistance remains an incredibly important priority. It's a critical priority. The work of the council helps to inform the policies and the strategies needed to protect the health of the American people. Antimicrobial resistance is often described as a silent threat, but its impact is very real. My career, until I got nominated and then confirmed into the position as the Assistant Secretary for Health, was as a urologic surgeon for over 3 decades. I know how difficult it can be to treat infections when the bacteria that we're up against have developed resistance to antimicrobials, unfortunately, oftentimes because of overuse of the antimicrobials of practitioners. Globally, antimicrobial resistance is associated with about 1.27 million deaths each year in the United States. More than 2.8 million antimicrobial resistant infections occur every year, and that results in over 30,000 deaths, actually over 35,000 deaths. So an incredibly important topic. But if we look beyond these numbers, antimicrobial resistance threatens the foundation of modern medicine. As I said, I certainly know from personal experience what that can be. Routine surgeries, cancer treatments, organ transplantation, and many other medical procedures depend on antibiotics that work. Addressing the challenge of resistance requires a comprehensive approach. We must continue to strengthen antimicrobial stewardship, which is incredibly important. Strengthen antimicrobial stewardship, invest in research and innovation, and improve surveillance and data sharing, and advance a One Health approach that recognizes the connection between human, animal, environmental, and food system health. And again, as a former practitioner, I know that oftentimes we overprescribe, we overuse antibiotics when we don't have to, or we use antibiotics that we could use something perhaps better in a given scenario. I'm sure that I've been guilty of that in the past. And so this advisory council is important. Prevention must also remain at the center of our efforts. Consistent with the goals of making America healthy again, we have to focus on building healthier communities. We have to focus on reducing the burden of chronic disease and supporting conditions that promote long-term health and resilience in the American people. There's no single organization that can solve the challenge alone. Success is going to require a continued collaboration across government, across healthcare, across academia, industry, agriculture, and public health lines. But I do appreciate your dedication to this important work. I want to thank you for that dedication. I'm looking forward to today's discussion. I'm looking forward to the valuable recommendations that will shape our nation's response to antimicrobial resistance. And again, thank you for taking the time to do this. And I'll echo what I think Dr. Plummer said. We're all busy, all of us. And so doing something like this probably adds more work onto all of your plate, but it's important what you're doing. So thank you so much. And thank you for letting me take a few minutes to address you. And I hope everything goes well today, but thanks again.
Thank you so much, Admiral Christine, for your thoughtful and insightful remarks and for joining us today. It really means a lot to hear from you. Now I will turn it over.
I'll say this.
Oh,
This is
please.
the first. No. I hope you don't mind. This is the first time I've been involved in something like this, so it's certainly exciting for me, interesting for me, and again, just realizing it's so interesting having practiced, like I said, for about 35 years as a surgeon. How little I really understood, and I think this is probably true for doctors, nurses, practitioners across the country, how little we really do understand of the important things that happen here at HHS, and the amount of work it takes to advance healthcare across the nation. Takes people at all different levels really working hard. So this is something new for me, but I think I'll learn from it. So thanks again.
Well, thank you so much, and we look forward to your continued engagement with us in our council. Thank you. Now I'll turn it over to Dr. Casey Sullivan to provide an overview and update of the National Action Plan for Combating Antibiotic-Resistant Bacteria. The floor is yours.
Wonderful. Thank you so much, Sarah. Good afternoon, everyone, and thank you so much for joining our meeting. As Sarah said, my name is Casey Sullivan, and I work in the Office of the Assistant Secretary for Planning and Evaluation, or ASPE, within the Office of the Secretary of HHS. ASPE serves as the coordinator of the Federal Interagency Task Force for Combating Antibiotic-Resistant Bacteria, and we're leading the development of this next National Action Plan. I want to start by expressing profound gratitude on behalf of the CARB Task Force to the co-chairs and the members of the Council for your ongoing dedication to supporting and guiding the U.S. government effort to combat antimicrobial resistance. We are so thrilled that you are here, and we are so thrilled to be here with you. To you and to our AMR community joining on the live stream, please know that today's meeting is part of the ongoing U.S. government commitment to a resilient and sustainable capacity to prevent and mitigate the threat of AMR and to protect the health of humans, animals, and the environment through the One Health approach. Our next step is to finalize the next iteration of the National Action Plan for CARB, and your input is essential to that process. Next slide, please. So Admiral Christine just gave us some of the top line numbers. Thank you for that. We all know that antimicrobial resistance is a leading domestic and global health threat. It is top of the agenda for everyone here. I won't spend too much time with this, but it is a great impact in terms of the number of infections and the number of people who are impacted every year. Next slide, please. The U.S. government works to combat AMR under the National Strategy for Combating Antibiotic-Resistant Bacteria, though we do cover resistance in fungal pathogens as well. The National Strategy has 5 goals, which I tend to shorthand to infection prevention and control and antibiotic stewardship, surveillance, diagnostics, therapeutics and other products, and then global engagement on all of those 4 under the 5th goal. Next slide, please. Actions to implement the national strategy are led by the Federal Task Force for CARB, which is co-chaired by the Secretaries of HHS, Agriculture, and War, and includes the Departments of Interior, State, Veterans Affairs, and the Environmental Protection Agency. The CARB Task Force truly embodies the One Health approach, collaborating to pursue strategic priorities through coordinated action. Next slide, please. We are more than 10 years out from the launch of the CARB initiative. The national strategy was published in 2014, and the CARB Task Force published the first 5-year national action plan in 2015. The national strategy tells us what our goals are, and the national action plans tell us how to pursue those goals, what actions we'll take in that 5-year window. So then the second iteration was published in 2020, and we're now here in 2026 working on the 3rd national action plan. Along the way, we've published reports on our progress, and we are excited to update the format of our progress reporting going forward, focusing on quantitative indicators. Next slide, please. So the first national action plan had goals, objectives, and more than 350 1-, 3-, and 5-year milestones, individual actions that the agencies were taking on those timelines underneath objectives, underneath the goals. The first national action plan established new data collection strategies that included integration across systems and across agencies, and it enhanced collaboration across One Health. Next slide, please. The second national action plan maintained the 5 goals of the national strategy. So everyone, when we got together to generate that plan, everyone agreed that we liked those 5 goals, and we still like those 5 goals. Instead of all of those milestones, we moved to a flatter structure where we develop new objectives and then targets, and we have various deadlines within the 5-year period there. We work to develop and include as many quantitative targets as possible, and those we sort of built in the capacity to update our targets annually as things evolved, and that was particularly helpful because we were implementing the first part of this plan during the COVID-19 pandemic. Our annual reports, again, included updates, but we also were reporting out on the challenges that we experienced while we were working to implement this plan. Next slide. So this next iteration of the National Action Plan for CARB, it's going to reflect the maturity of our initiative here after 10 years. We are maintaining the same 5 goals again. We are establishing a new vision statement that describes what we hope the future will look like if our efforts are successful. We are setting new, broader objectives to be more inclusive of a broader range of activities, but also we don't feel the need to have the level of granularity that we had back in the first national action plan with 350 milestones, because so many of the activities are foundational and continuing now. And we will be tracking progress through quantitative indicators, and we're very excited. They fit together because we're going to be pursuing these objectives. We will keep track of the indicators with the hope that they will tell us whether we are moving in the direction of the vision. And that's how those pieces are fitting together. So that is all I have. Thank you so much for your input. I wanted to just sort of highlight the way that the national action plans have evolved over time, and along the way that the input of the council has been absolutely essential. And we are so looking forward to this discussion and to your input. Thank you again.
Thank you, Dr. Sullivan. We really appreciate that great overview. Now, council, it's time for us to get to work. And I'm really excited, and it's my pleasure to do the first goal: slow the emergence of resistant bacteria and prevent the spread of resistant infections, or as Dr. Sullivan shortened it to, antimicrobial stewardship and infection prevention and control. Here are the questions. Number one, what aspects of goal 1 should the PACCARB task force prioritize for implementation? Number 2, how can federal agencies further strengthen and provide sustained support and encouragement for cross-sector collaboration at the local operational level, for example, data sharing, joint response protocols, etc. Number 3, how can partnerships with producers, industry groups, and extension services be strengthened to enhance AMR detection, prevention, and response? For which audiences, public, clinical, veterinarian, agriculture, environmental, are currently underserved by our communication efforts within AMR? And then lastly, how can research priorities on antimicrobial resistant prevention and response be aligned and harmonized across the federal, academic, and industry sectors? The rules are the following. You can answer any of these questions. We have limited time. Please refrain to one comment. We don't need any soliloquies or monologues. One comment, please, focused on these questions. 2, please raise your hands and I will acknowledge you. I look forward to help from Sarah and group as we move forward. And I think with that, I'm ready for the first comments regarding these questions. I mean, this group is usually talkative, very much so. Yes, Dr. Kwan, thank you. I was going to call on you anyway.
I really want to comment on the question regarding which audiences we are not serving well in terms of talking to them about AMR. I think we've done a really good job in informing healthcare providers. We can do better. But really, I think the public needs to understand more how AMR directly impacts them, not just now, but in the future. And when I say the public, I don't just mean all the people living in larger cities, but I think also in other communities. I just came from Missouri. Jason, you know Missouri well as well. And I think places like bigger cities need to understand a little bit more about the impact of AMR. CDC did a great campaign in the past, but I think we can build upon that. Over.
Thank you, Dr. Kwan. Okay, Dr. Jacinda Abdul Mutakabir. Hopefully I got that correctly. Thank you for being here.
Thank you. Thank you for having me. Thank you so much, Dr. Kwan. I would say I absolutely agree with you in terms of public communication. I think in terms of clinicians, I was excited to see that the American Dentistry Association had submitted comments. That is a discipline I would say that we don't really emphasize AMR and how we can better steward antimicrobials in the dental arena. But I think in emphasizing also communication to the public, really talking to individuals of the public about how they too can steward the medications that they may be given by their dentist as well.
Thank you. Dr. Patel.
Yes, thank you, Jason. This is in response to the question on how can we cross-cut on important issues from different sectors. I think something that we could think about is potentially funding agencies working together on a call for AMR. So whether that would be human animal industry partnering across industries to address some of these issues could be really impactful, and I think could answer some of the questions that we have. Over.
Thank you. Dr. Wong.
I wanted to also address the question about audiences and just raise the importance of long-term care as a major area that has a prevalence of multi-drug resistant organisms that are many, many fold higher than hospitals, and has been seen in multiple areas as a reservoir that then extends out both into hospitals and into the community.
Oh, that's wonderful. Yeah, thank you. That's really key. Dr. Plummer.
Just following up on Dr. Patel's comments, as it relates to the question about how can research priorities on AMR prevention and response be aligned, I would echo the comments. And I believe that in order to align those research priorities, we need to address disparities in funding levels between those different sectors of One Health. And we need to promote those transdisciplinary research projects that really span multiple agencies. As we've talked about before, many of our scopes of research in this field are divided into different agencies, and some sectors like companion animals and pets don't really fall really well into any of those agencies. So I think and would encourage the National Action Plan to look for ways to broaden those transdisciplinary projects that bridge agencies and build in that opportunity to take a comprehensive 360 evaluation.
Thank you, Paul. Dr. Whittam.
Paul kind of introduced the idea that I was going to mention as well, because the companion animal veterinarians are definitely an underserved audience for AMR information. We're seeing in our own surveillance here in Ohio, we're seeing a rapid increase in clinically relevant AMR bacteria in companion animals. I think the practitioners don't really recognize their role in that. Their clients certainly don't. And I think additional targeted information for them could be very helpful.
Thanks, Tom. Dr. Patel?
Thank you. I just wanted to comment that this goal really ties into some of the other goals because it's about slowing the emergence of resistant bacteria and then preventing their spread. And I really think that these are important. We need better data and diagnostics to help us with this so that we can come up with strategies that will really address prevention of spread and mitigation of emergence of resistance.
Thanks, Robin. Dr. Lucas Pantillon.
Thank you, Jason. This is regarding how federal agencies could further strengthen and provide sustained support across disciplines. And I think, continue the funding of educational, informational resources such as workshops or videos led by, industry, key opinion leaders will help to drive behavior and try to change, the way we use antibiotics, the way we provide biosecurity at the farm level in the animal agricultural sector.
Great.
Thank you.
Thanks, Lucas. And I want to just, the counts, you're doing great. Thank you for the focused remarks. Dr. Marks.
Thank you. Yeah, I'm just going to build on the theme of connecting organizations by also indicating maybe a connection across disease areas, if you will, from AMR. And for example, in human health, infections in the warfighter, public health emergencies, healthcare associated infections, hospital acquired infections, sepsis, biothreats, multiple organizational groups aligned around that. That Venn diagram of overlap with AMR is massive in terms of morbidity, mortality, and economics. Thank you.
That's great. Thank you. Dr. Wong.
I just want to talk about the strengthening aspect. As we talk about this is the section for slowing and preventing. And one of the major issues is we're quite good at guidance, but we haven't really figured out how to do adherence training, human psychology, behavior modification, as well as our workforce numbers are lacking. So I wanted to add those. Thanks.
Well, that seems like a perfect segue to the next speaker, Dr. Simzak.
Thank you, Dr. Newland. And again, it's wonderful to be meeting with the council again. And so this is just a comment in relation to the question on research priorities. And I think it echoes a lot of what we've heard others already talk about, the importance of conceptualizing AMR as a transdisciplinary problem, and that, you know, we really have made great strides in the last decade of generating evidence about how to use antimicrobials appropriately, and even novel socio-behavioral strategies about changing how clinicians use these drugs. And I think we need to continue our investment in research on how we implement this evidence, particularly paying attention to the many contexts in which antibiotics are used. So it's not just your primary care office, it's in telemedicine, it's in companion animal medicine. So really emphasizing research on contextual adaptation and how we get the evidence about what we know works to actually be influencing clinician behavior and patient behavior. Thank you.
Thanks, Julie. Dr. Burbick.
Yeah, I guess I would just kind of take one step back from kind of that level of research. On the veterinary side, I think we really still have some gaps in how we should best use our drugs. And so having more available support for doing some more clinical trials, to doing more breakpoint development. You know, I think there's a lot of gaps that need to be filled on just should we be using these drugs for all the myriad of animal species, is pretty critical, because, you know, if we don't have the data to suggest how we should be doing, you know, our drug usage, then we really are really already in a bad position for mitigating resistance. So that's one point. I think the other point, though, that I've gotten, you know, a lot of feedback in trying to do work in antimicrobial stewardship on the veterinary side, is that people really just, they want very practical information. And if stewardship can be sort of wrapped up in that practical information, I was kind of told point blank at one point that if I'm doing continuing education, if I say antimicrobial stewardship, people will not attend. And so having it be like, you know, what are, you know, new recommendations for treating urinary tract infection, and you're kind of rolling this into a stewardship perspective. So, you know, maybe it's a little bit about what the previous speaker or commenter said, is that, you know, how do we deliver this information in a way that people really find very usable and accessible? And I think it is also important on the veterinary side.
That's great. Thank you, Claire. Dr. Jenkins.
Well, thank you very much. I'd like to pick on upon a point introduced by Admiral Christine, which he talked about focusing on reducing chronic diseases. I think that's really important, because there's often an unfortunate disconnect between chronic diseases and infectious diseases. Many infections requiring antibiotics are a consequence of chronic diseases, and we don't make that connection enough times. I think we ought to be looking at the root causes of chronic diseases, in particular things like smoking, alcohol, bad food, and inactivity. And you're looking at how improving reducing smoking, reducing alcohol, better food, better quality food, and encouraging activity can reduce chronic disease, which then leads into reduced need for antibiotics because the infections don't occur. I mean, very quickly, thinking about cardiac surgery, sternal wound infections, the commonest cause of those is cardiac surgery. Why do we have cardiac surgery? It's smoking, lack of exercise, bad food. Attacking those will reduce the need for antibiotics and therefore reduce the driver for AMR. So thank you very much.
Thank you. I'm just going to say, Dr. Abdul-Muktagbi, you'll be the last question. Dr. Patel, you'll be the last question, then we'll be done. Dr. Black.
Hi, hopefully you can hear me. It's great to be back with PACCARB. All right, great, thumbs up. Okay, so I'm addressing the second point. So how can federal agencies further strengthen and provide sustained support? And I wanted to speak to the issue of workforce, in addition to infectious disease physicians and pharmacists. Do want to lift up that your local and state public health departments who employ infection preventionists, and that they serve as the bridge often to places that don't have that kind of support, like long-term care facilities, as Dr. Wong. So partnership between public health and academic centers can bring research that's in place that where we have known outcomes to bear fruit in settings where this is needed. So both in the lane of infection prevention and control and also stewardship. That's it. Thanks.
Oh, and by the way, we still have a lot more time. I looked at the agenda wrong. So we go to 125. So everyone's looking at me crazy. You were right. Okay. Dr. Abdul Mutakabir, you're up again.
Thank you so much.
Sorry,
Back to Dr. Jenkins's comment about the syndemic relationship between non-communicable and communicable diseases. I wholeheartedly agree. I would add on to that and say that we need more host pathogen research for AMR. Not every antimicrobial therapy is the same for every host. And I think we need a lot more research that connects that. I would add that the CDC currently has the Social Vulnerability Index, which is currently being used to kind of navigate antimicrobial resistance. And if we see rising rates of resistance in areas of different geographical areas, which I think is phenomenal, and that'll really allow us to tailor the diagnostics and therapeutics and so on that we use. However, the SVI is not optimized for this purpose. So I think revisiting that as a tool and working to optimize that so that it is one that we can use to identify resistance and best allocate treatments and diagnostics would be helpful. So I say put in research towards those matters.
Great. Thanks, Jacinta. Dr. Patel.
Yes, thank you. This is to address the first question. What aspects of Goal 1 should the CARB task force prioritize for implementation? As I reviewed the previous National Action Plan, I do believe that we've made a lot of improvement in inpatient as well as outpatient stewardship for human use of antibiotics. And outpatient stewardship was mentioned several times in the last National Action Plan, and we have actually, I believe, made a lot of progress towards the objectives outlined in the previous National Action Plan. I would advise CARB as we move forward to really focus in on what can we continue to push in the outpatient space in this area where we use a lot of antibiotics so that we can achieve some of the same goals on the outpatient space that we have been able to achieve on the inpatient space. Over.
Great. Great job. Thank you, Kyle. Okay. I'd like to hear if on the prevention side, I think Dr. Jenkins, you kind of really got into that spot. Can anyone want to speak a little bit more on prevention, whether it's in animal health, anything? I think that's another piece I'm really intrigued about. How do we do more prevention? Because if you don't see doctors, you don't see these things, you won't need these things. Go ahead, Claire.
Yeah, I guess this is a good place to mention it. So APIC has recently been supporting veterinary infection prevention and control. And so it's kind of a really nice synergy or collaboration, I think, between this very well-established organization dealing with infection prevention and control, really supporting veterinary partners in developing more training, more training materials, more resources. We recently have Karen Elroy at the New York City Department of Health put together a first-line app for veterinary infection control and prevention and control, which we are all like really, really excited about. And so I think there's a lot more interest, a lot more organization around developing veterinary specific guidance for infection prevention and control, but it's under this guise of a larger human organization. So, I think because we don't want to rewrite the wheel and do all of these things, even though there are some very large differences. Obviously, a farm and a hospital are like really divergent. But, a lot of the support structure can, I think, be leveraged to get us pretty far down the road on dealing with some of these kind of fundamental prevention things as well. And I think supporting these different veterinary healthcare delivery sites, whether it's out in the field or in a more formal setting, I think it's would be a really, really valuable place to invest. The other thing is, especially, you are dealing with a lot of people who are caring for animals, so you actually get kind of an occupational therapy added bonus in that situation. So I think, support for some of these, burgeoning or developing groups, even though they're a bit small at this point. There's a lot of enthusiasm and momentum, I think, looking at how do we push forward, more resources for veterinarians where we haven't maybe had as much in the available for us.
That's great. Thank you, Claire. Dr. Wong.
I think culture change requires communication and messaging, and we think about the way we do them in respective silos, to humans, to hospitals, outpatient, to animals, and other providers. But I think that it requires a concerted effort, because people in their families, when they have communications, they're not siloed. The conversations that come up are mixed, and it would be really good if we could time and joint communication and messaging to be active in all sectors for certain campaigns at the same time. I think it would have a greater benefit.
Thanks, Susan. Dr. Plummer.
I appreciate your prompt on this, Jason, and prevention certainly I think is a key and should remain a major focus and aspect of goal 1 that's prioritized. As we all know, every use of antibiotics has the potential to result in increasing emergence of resistance. And so the more we prevent, the lower our burden. Certainly stewardship is important in that process. But as we think about prevention, I think we need to approach that broadly. And so that is, how do we prevent disease? But that's also, includes mechanisms of healthy microbiota. I think it also, looks at how do we manipulate or use antimicrobial alternatives as part of that. So that starts getting over into the stewardship side, but still falls into some of those prebiotics, immunomodulators, and certainly vaccines in some cases should be considered in that process.
That's great. Thanks, Paul. Dr. Zimzek.
Yeah, and thinking about this, I know that later on we will be talking about improving diagnostic testing, but I think it's also important under goal 1 to emphasize the importance of improving diagnosis, diagnostic safety, diagnostic quality, and recognizing that diagnosis is a socio-behavioral phenomenon, and that we have lots of really interesting improvements in clinical decision support. I'm curious about the role of AI and essentially helping clinicians get to the right diagnosis faster to prevent the overuse of antimicrobials or getting the right antibiotic to the patient at the right time. And so I think goal 1 does have a place for to think about diagnostic safety as part of our efforts. Thanks.
And Julie gets the first AI reference in PACCARB 2026. Thank you, Julie. Dr. Marks.
Yeah, thank you. I'm bouncing a little bit, Jason. I apologize, but
That's all right.
Thinking back to the messaging to public and healthcare professionals. I think when people say stewardship, most people believe that's code for don't use, as opposed to healthy prescribing, healthy use, something that is more of a positive spin rather than I want to give you the cheapest, least antibiotic I can possibly find, as opposed to other terminology. Thank you.
Great. Thanks, Lynn. Dr. Zagman, how are you?
Hi, how are you? Yeah, I think it's an interesting discussion. I wanted to address your prevention point and also which audiences are currently underserved. I think definitely on the ag side, there is quite a bit of a gap to try to understand what works, what doesn't work. A good example is tulathromycin, rather, for bovine respiratory disease. It works really well metaphylactically. It's very cheap. How do we align incentives to do the right thing when you have a highly effective cheap medicine that right now works, right? And I think that has to do with the part of aligning, harmonizing across federal, academic, and industry sectors.
Great. Thanks, Francisco. Dr. Kwan.
Hi, for research priorities, I really would like to highlight that for the prevention question to be thinking about the microbiome. And what I mean is the presence of an organism or a pathogen without the infection in play. So I really think we need to be thinking about it from a diagnostic standpoint and a therapeutic standpoint, so that if someone is colonized with these organisms, we can detect it and hopefully prevent them from getting an actual life-threatening infection. So we'd love to hear a little bit more about the microbiome in future discussions.
That's great. Thank you, Jenny. Dr. Patel.
Thank you. I just wanted to come back to what I feel is the importance of this goal for PACCARB to be addressing, because preventing emergence of resistance and preventing spread of resistance is important, not just for the individual, but really for the whole American population. I'm a physician, and a lot of times as physicians, we think about our patients. The way our healthcare system is set up is at a very individual level. So having the government take a look at what can we do as a country to prevent getting to a worse place in the future, prevent bad outcomes in terms of spread and selection of resistance is very important. And I think uniquely, the government needs to be involved in this area.
That's great. Thanks, Robin. Dr. Marks.
Yeah, I think in terms of the overarching goal of emergence of resistance and spread, et cetera, I think we have to refresh and revitalize our interest. I know we'll talk about this in Goal 5, but internationally rather than just focusing that if we handle it in the U.S., we'll be okay. I don't think that's a winning strategy.
Right. Thank you. Thank you. Dr. Jenkins.
Thank you. Something less abstract. You talk about antimicrobial stewardship, and people say they're doing it, and that implies it's a fairly homogeneous practice. But in reality, there's a wide variation in practice. There is some good AMS and there's some really bad AMS. Accreditation is a really fantastic quality improvement tool. I think promoting accreditation of AMS activity, specifically AMS, rather than whole hospital accreditations as you get with Joint Commission, I think focusing in on AMS accreditation would be very beneficial. Thank you.
Yeah, no, thank you. Thank you. We got about 3 minutes left. Thank you, Dr. Marks.
Yeah, I'll throw one more in there on the harmonizing our objectives across government, academics, and industry. I think we have a great opportunity as Dr. Sullivan puts out the next version of the National Action Plan. Maybe there's opportunity to actually engage in public meetings or whatever mechanism with those groups, because I don't think it's going to be by chance that we align on objectives. It'll have to be effort. You'll have to understand those audiences. And I think that might be some fertile ground for trying to hit that final bullet point.
Yeah. You know, I will say my comment on this amazing goal and important goal is I've always been in kind of my later career, most of you know, and I try to say it probably once or twice at PACCARB meetings, that I'm from a small town in Southwest Oklahoma. And so rural America it means a lot to me. And I'm always wondering how in human medicine can we use the extensions, and how do we leverage that amazing advancement to improve agriculture? So how do we use that even in human medicine? And where does that come in? Because I think, you know, the fusion of innovation theory, all these things was born out of the extensions. And I think that's how to at least continue One Health learning collaborative, essentially. And doing that, I think, is key for us going forward. Anybody want the last statements, or do I get a yes?
Go on then. So if we're talking about infection prevention, it's patients, pathogens, practice, and place. We haven't really talked about the healthcare environment as a factor in preventing or promoting healthcare infections. And I think I suspect there'll be some significant variation in the quality of healthcare facilities in the US, as there is certainly in the UK. Looking at that and seeing what is good building, what good building looks like, bad building looks like, in aspect, both for current practice, but also potential as well.
Great. Okay. I just want to applaud the council for just an outstanding session, even working through my little bump. You guys are fantastic. I appreciate you tons. And with that, I will turn to Dr. Plummer for goal 2.
Thank you, Jason. 1 goal down, 4 to go. So thank you to the council for keeping that conversation going. Now we're going to move into goal 2, strengthening national One Health surveillance efforts to combat resistance. Here, there's 3 general questions that we're going to explore. First, what are the gaps and areas needing improvement in the U.S. government's current antimicrobial resistance and use surveillance across the One Health sectors? Secondly, what role can the U.S. government and stakeholders play in improving surveillance infrastructure and technology? Please consider timely collection, reporting, accessibility, and quality of the antimicrobial resistance and use data across the One Health sectors in your response. And third, how can better antimicrobial resistance and use data aid in the development and implementation of targeted and effective AMR prevention and control efforts? In thinking about improvement, please consider data collection, reporting, and accessibility across the One Health sectors. Again, we will be using the raise hand function, so I encourage you to raise your hand. I will call on you on the order that that hands are raised. I'm going to open the floor to responses to all of these questions. So if you can just preface, and if there's intersection between these questions, feel free to to address those as well. And I will call on participants. And again, please keep your comments to one comment at a time. And if we have time, we'll come back around and give folks another opportunity. But please keep your comments focused and short to begin with. So, Dr. Pantaleon.
Thank you, Paul. So I guess this is a key objective of how we can actually know what's happening out there. But I think, at least speaking from the animal agriculture sector, building trust between the producer and the government and how that data could be acquired, kept private, and don't be used for punishing the producer is a key worry out there. So I think collecting data and understanding what's happening at the farm level is fundamental to understand AMR, but how we can keep that data safe is also very important.
Thank you, Dr. Pantaleon. Dr. Marsh.
Thanks, Paul. Yeah, sorry to be a broken record on Goal 5, but it says strengthen national One Health. I assume we also want to make sure that we strengthen and trust and coordination internationally as well, would be my comment on the gaps and areas needing improvement. Thank you.
Thank you. Dr. Papich.
Yeah, thanks, Paul. In the last session, somebody mentioned or brought up that we need more data or more information on what works and what doesn't work. And in veterinary medicine, I think all of us would agree we would have a goal of reducing antibiotic use as much as possible. But it's hard to measure and it's hard to implement. So but there is some data that we could possibly explore. Here in the United States in veterinary medicine, there's not a whole lot of restrictions on antibiotic prescribing. There are a few things that have been implemented in recent years in food animals, but not much beyond that. But if we look to Europe, there are some really interesting developments over there. For example, since 2023, it is illegal, not just restricted, but illegal to prescribe antibiotics from the highest priority critically important class, even for small animals. They cannot prescribe those, it's illegal. So the use of those antibiotics has been reduced to essentially zero. In some of the countries, particularly the Scandinavian countries, veterinarians can no longer dispense antibiotics the way they do in the United States. That's been eliminated. They have to write a prescription that has to go through a pharmacy. And because of that, the antibiotic use has been reduced dramatically. What we don't have, however, is what is the impact? In other words, what works and what doesn't. If any of those efforts were ever considered here in the United States, we would need to point to whether or not it has been successful. So, and in Europe, they do have some pretty good monitoring programs. So I would suggest that at some point, if we could, to mine that data and look for evidence to know whether or not these restrictions, severe restrictions in some case, have had some impact on antimicrobial resistance. Thank you.
Thank you, Dr. Wong.
I wanted to mention that I think the technological advances of this age allow us to really explode the way that we understand reservoirs and expansion of antibiotic resistance, and the way that we can actually track and look at network analysis to a much greater degree. People move, animals move, food sources move, antibiotics move, and we're not able to really see all of that picture without a lot of technological data and prowess, but I think that time has come.
Excellent. Dr. Newland.
Yeah, I would like to focus on the first question, what are the gaps? We know that CDC many years ago developed the antibiotic use and resistance module, as they also did with antibiotic use. My feeling is it's not been elevated or used as it should. And I think part of that is the data infrastructure that is coming from all the unique hospitals and clinics and stuff that are putting this data in and the different methodologies. Whether that's right or wrong, I'm not saying. I'd say that, but we need to have a better system or a system that we're really dedicated to doing this, that then can actually then look at it differently across the different sectors and populations. I'm a pediatrician. I really want to know what's going on maybe in the neonatal intensive care units versus what I want to know that's going in the medical intensive care unit for someone else, and how that overlaps, I think, is important. And how can we advance that piece? I'd love to see, and hopefully maybe I'm wrong, and there's more work done that I'm not aware of.
Thank you, Dr. Newland. Dr. Black. I think you're still on mute, Stephanie.
Seems like my audio in and out. Okay, if you can't hear me.
We can hear you now.
Okay. I'll keep talking then. All right, I actually wanted to pick up on your point, Dr. Huang. So I wanted to speak towards genomic surveillance and the availability of sequence data through NCBI and how beneficial that has been through NCBI pathogen detection. So looking into CRE outbreaks in humans and animals. But as I understand it from talking to colleagues, NCBI virus is much easier to use. And so this is speaking, by the way, to point number 3, like improving resistance data for use. So making that NCBI pathogen detection easier for locating and accessing sequence data would be a huge help in cross-sector surveillance and collaborative work. Thanks.
Excellent. Dr. Simza.
So this is a comment in response to the last bullet. How can better antimicrobial resistance and use data aid in the development and implementation of targeted and effective AMR prevention and control efforts? I think we know that one of the most effective strategies to change clinician behavior, which is my area of expertise, is audit and feedback of performance data. But there are a lot of challenges in getting data that is timely, getting data that is meaningful, getting data that is tied to behavioral targets of change. And so I think thinking more about the development of actionable measures and metrics that really can be utilized at the more individual clinician level, could be a really impactful way to go about improving the implementation of stewardship. Thanks.
Thanks, Julie. Dr. Patel.
Yeah, thank you. This is also in response to that last question. How can better antimicrobial resistance and use data aid in the development and implementation of targeted and effective AMR prevention and control efforts? This is somewhat building on Dr. Newland's previous comments. I think what I want to highlight is that it's taken over a decade for the CDC to really, over a decade ago, we had none of this information. And now we're close to 100% of U.S. hospitals being able to deliver some sort of antimicrobial use data as well as AMR data, which I think, just to highlight how long it takes to start building some of this data. And now the next phase, I believe, will be fine-tuning that. And so hopefully adding more units, understanding how they compare, and then going to that next level of understanding how do you implement based off of this data. And so I would say as we start building that up in other sectors, really thinking about the long-term maintenance. It's not a one-time effort. We need, focused efforts, cross-cutting again amongst sectors to help build and then maintain over decades so that we really can use this data for action.
Thank you. I'm sorry, we're still going there, Dr. Patel?
No, over.
Okay, thank you, Dr. Patel. Now, Dr. Robin Patel.
Thank you so much. I actually really want to jump on that comment. I think this is very much a changing game, and we need to stay on top of this. So lessons that we learned a year or two ago may not be the same as the lessons that we will learn today in this area. So it demands ongoing efforts. I spoke last week at a meeting in Hong Kong called the International Symposium on Antimicrobial Agents and Resistance. And I don't want to get into details, but there was some very shocking data on the presence of ESBL and carbapenemase producing gram-negative bacilli in the meat supply, as well as in ready-to-eat food products. This is in Hong Kong. It's not in the US. But, we do need to learn from others, and we need to see what's happening here and figure out how this is happening as well, because that wasn't clear. With genomics, we can look and see what is happening, but we have to answer the why as well. So I just think this is a really important area. I don't think all antimicrobial resistance is a One Health problem, but some of it surely is.
Yes, thank you, Dr. Patel. Dr. Berwick.
Thanks. I just wanted to, address one of the gaps that I think at least I definitely have seen and run into in my own work is that we really don't have a lot of environmental AMR data that is easy to compare to what we have on the human and veterinary side. I think sometimes the methodology is quite different. The goals are quite different, but we're still trying to utilize that data in conjunction with trying to compare human and animal data as well. So I think there is a big gap in how we're surveilling for AMR and how translatable or comparable that data is in sort of that big One Health kind of lens. So I would suggest that more support for more standardized testing for AMR in the environment. I work a lot in fish and aquatic environments, and so I think there's a lot that we could learn from how these are all interconnected, especially if we're using some of these drugs sort of in the environment. How is that impactful, and can we leverage some of that data as well?
Thank you, Dr. Berwick. I'm going to take a moderator's privilege here and say I think I really appreciate you bringing that point up, and because as you point out, on either end of that with the human and animal, most of the time our diagnostics are driven by phenotypic testing or a desire to know phenotype, as it's going to influence our therapeutic intervention. In the environment, that's very different. We're looking at much larger communities and typically using genomics-based different approaches there, and then that makes it very difficult to we can't always get genomics on the human more so, but animal side and vice versa. In the environmental side, we almost never have phenotypic data, at least at scale, and so really appreciate those comments. Dr. Kwan.
This comment focuses on gaps. This has been brought up early on, but I do think it's essential we think really critically about the way we collect data, what elements we collect, the minimum requirements, and then how the methods of sampling can be more standardized. Because when we do collect these data, a lot of times they're all scattered and many of us are siloed. I think, though, that when we do get these data, we have to be transparent as well about the data sharing. A lot of these data may not be well publicized in a forum that's easily accessible. For instance, I didn't learn much about veterinary science or agriculture or environmental science until I was a part of this group. And so I really think that we need to focus on how we can get these data to a more standardized fashion, and also with the data sharing transparency element.
Excellent. Dr. Pantaleon.
So thanks. And kind of following this trend is a very interesting article that I read last week in preparation for a conference that I gave a talk by Angel et al. At the Journal of Global Antimicrobial Resistance, which they talk about the lack of standardization of international definitions for multi-drug resistance, definitions, and the lack of consensus. So trying to harmonize definitions and how we can provide optimal visualization so we can compare across populations and across disciplines is very interesting, so we can understand each other about what we're talking about. I think is something that maybe we need to refer to that paper and try to lead the way on that.
Thank you, Skinner.
Expanding on the genomic work, I want to encourage the thinking of how to apply genomics and wastewater surveillance to also zoom out to the population level and understand trends with some of these things, in addition to the clinical and hospital data as well.
Thank you, Dr. Black.
I think there might be a delay. You can hear. Okay, so I'm adding on to what Dr. Pantaleone was talking about, but in terms of gaps, and that is having standardized case definitions. In human medicine, we have the Council of State and Territorial Epidemiologists. So make sure when we're surveilling for drug resistance infections, we're talking about the same thing, and we need the same for animals. And then, as has been mentioned, the environment and also plants. So all of those are really needed. So just wanted to bring that up as thanks.
Thank you, Stephanie.
And I guess bodies to make those definitions. So kind of assigning that. Okay,
yes.
Thanks.
Thanks, Stephanie. Dr. Burbick.
The other thing that I think is a gap, and maybe this kind of plays into the, I think Luca's saying, not have this data be used in kind of a punitive way, is that a lot of times, because of the cost of doing testing, susceptibility testing and antibiotic and bacterial culture, we miss a lot of data on the veterinary side. And I think, it would be very beneficial if there could be some mechanism to support diagnostics in lower resource places, or where people, really don't have that as necessarily a priority or something that, really is going to change what they do in their production necessarily, which is why you would want to do a susceptibility test. Is going to change your prescribing in a lot of places. That isn't necessarily what's going to happen. And so how we can actually get more data, I think, is an important consideration on the veterinary side, because it really is up to either the pet owner or the producer to pay for these diagnostic tests, or things that might be for the greater good, but not going to necessarily benefit their animal or kind of their bottom line. So if there could be some incentives or some kind of financial support or benefit to these people to do this type of testing, we just can't have all sticks. We have to have some carrots for people to be able to buy into this. And I think on the veterinary side, we really haven't gotten any of those in place to really support people buying in to stewardship and doing more surveillance. It's just always like, what evil thing are you going to do with this data? So I think if there's a way to try and incentivize that for them, to not have it be onerous or a burden or a potential detriment to, how they're trying to care for their animals, I think that would be another that would be really huge for us on the surveillance side.
Thank you. Dr. Zagman.
Thank you for a great discussion. I think picking up on this issue of genomics of surveillance that covers both gaps and the surveillance part, we do have an excellent program ongoing, at least on the foodborne pathogen side of things, is NARMS, where we have excellent data both in humans and meat products, mainly. What is missing a little bit on that program will be on the animal side. We do have some animal collection, but it lags behind compared to the rest. I'm talking about in a project ongoing in our group, we have over 90,000 genomes, and out of those, the vast majority come from humans or meats. And the other aspect on a One Health spectrum, I think, is if we want to understand, to one of those points here, the impact of stewardship and antimicrobial use restrictions, we also don't have a good program tying antimicrobial use, resistance, and ultimately treatment failures, neither for the animal side nor for the human side, as far as I know.
Thank you, Dr. Newland.
As I listen to the conversation, I look at the question 3 about antimicrobial resistance and data. I think to myself, if I went around to my colleagues in the hospital I work, which is a large children's hospital in Columbus, Ohio, and I said, hey, what's our antimicrobial resistance rate? I probably would get a lot of different answers. Maybe some would say, well, we have MRSA that's this, or E. coli is that, but I'm not sure anybody really knows what that means. And that's of the experts, right? That's the experts. That's probably people next door to me who are pediatric infectious disease doctors, and they'll have an opinion. Which then begs the question, how's the public supposed to know? So it seems like a major gap. And I should say lastly, Dr. Whittam, who's down the street from me, just says something about companion animals and resistance. I'm like, oh, that's interesting. But how do you then marry that together and then say, hey, this is the problem, this is the intervention, that's next? We haven't even figured that out, I think. And maybe even to decide where we are at a threat level, what that means. How do we get better there and not wait for a CDC threat report every 5 years?
Thank you, Jason. Just kind of logistics wise, Dr. Marks will finish with your comments. I'm going to go to the others, but yours will be the last hand raised. And so going to Dr. Whittam.
I just wanted to follow up on some of the comments about genomics of AMR and how that fits in with surveillance, because I really believe that resistome-based surveillance is the future of AMR surveillance. I know Jay and some other groups have been doing a lot of that work already, but I think we all recognize the limit. There are some limitations to that approach, and some of that have been mentioned are the applicability to the clinical setting and how we can use them to for deciding how to treat patients. So I think a real need in this area is to help us to have better tools for resistome-based surveillance.
Great. Dr. Berwick?
I guess I just wanted to plug another gap, which is just training specialists in these areas in vet med. We have very few programs that are training veterinarians kind of deliberately in this space. We have a few post-veterinary graduate programs in clinical microbiology, but not necessarily in dedicated to work in this area, or internal medicine folks who are specially trained as ID internal medicine veterinary people. So I think in order for the surveillance to really be of value on the veterinary side, and for us on the veterinary side to interface with these other One Health partners, we really need to have more concerted training programs around how this data coming out of the veterinary world can then be amplified, can be analyzed, can be shared across these spaces with the kind of their kind of co-trained partners in these other One Health things, because we just don't have a concerted educational structure for specialists to work in this area.
Great. Dr. Abdul Matakaba.
Thank you. One thing that I thought about as Dr. Black was speaking was really incentivizing or encouraging the sharing of just the antibiogram of hospital institutions with the departments of public health to help with just consistency as we are prescribing. I think that can really decrease AMR. When I think about so many therapeutics that come from the veterinarians, that come from dentist office, that come from PCPs, I think having state-specific antibiograms would be helpful for guiding treatments for therapies.
All right, Dr. Marks.
Thank you, Paul, for allowing me to yet again expose my ignorance in a topic. I'm not a veterinarian. I'm trained as an adult ID physician. But when I put myself in terms of gaps in surveillance and try to put myself in the position of a veterinarian, it does feel like a lot of our messaging would be counter to me wanting to volunteer to be participant in a surveillance kind of thing. Because, antibiotic use in animals is bad. You're part of the problem. It's a simple thing to answer. Just quit using antibiotics in animals or decrease it drastically. So I as opposed to that positive partnership, what's in it for you, the greater good, those are all wonderful things. But on a business point of view, I'm not sure how well it resonates. Again, I'm probably way out to lunch here, but it just the terminology we use makes me, if I were a veterinarian, be hesitant to want to join in and expose that I've got a problem. So what's the implications of that? Yeah. Anyway, I'll stop there.
No, I think as a veterinarian, Lynn, I agree with those comments, and I do believe that impacts our ability to engage all those sectors. So as we start to wrap up, I see Dr. Sheftel. If you've got a quick comment, Dr. Sheftel, we'll get you in before we close.
Okay, thank you. To that last comment, especially, a specific diagnosis helps all veterinarians and producers justify their use of antibiotics. So instead of so much worrying about the negative impact of all that we hear around us as veterinarians and producers, if we could support our veterinary diagnostic labs and make it more economical to actually reach a specific diagnosis, that would result in a lot of stewardship happening and also an ability to absolutely justify any use of antimicrobials that there is. And I say this every time at PACCARB, but we need to support our state veterinary diagnostic labs. The support has eroded over decades. Thank you. That's it.
Yeah, I appreciate that, Dr. Sheftel. So as we go to close this goal, I just have one or two additional comments that I think summarize some of the multiple comments we've had. One of those, and this was brought on, I believe, or brought up even in the first discussion, and that relates to privacy. So in the human health sector, we have HIPAA that provides a well understood framework for managing sensitive data. In contrast, animal and environmental AMR data is often not governed or is governed in fragmented and less mature privacy, confidentiality, and data use protections. And so this lack of trusted standardized framework increases concerns about identifiability, liability, reputational harm, and economic impact, which in turn discourages sharing data across those One Health domains. And so I've said this before at PACCARB, but I think until we deal with that issue and have statutory data protections or some other mechanism to provide protections for personally identifiable information in this data, we're really going to have a hard time collecting it across the One Health spectrum in a manner that's truly kind of consistent and shareable. The final thing, and this relates to Dr. Sheftel's comment there, is, we do have some good examples. I believe Francis brought up NARMS. There's some other great examples of, the FDA Vet Learn and APHIS's AMR dashboard projects. And all of these are designed to start down the pathway. My lights are going off. Start down the pathway of building these One Health comparable data, but all of those struggle for continuous funding and struggle for significant funding and haven't yet today really pulled in the environmental or crop side of those aspects. And so I think this is a place where we have early wins. We have kind of a potential roadmap, but we need more investment of time, energy, and resources to make that happen. And obviously that relies on Congress and appropriations, but just believe that that's an opportunity that we have to lean into addressing this goal. So with that, we are going to transfer our interest and questions to goal 3, and I'm going to turn it over to Dr. Payal Patel to lead us in this section. Dr. Patel?
Thank you so much, Paul. Yes. Okay, guys, we're at goal 3, and I hope that we can keep this good speed going. And so I'm going to tell you the goal and the questions, and then I'll talk to you about the flow. So for goal 3, we're talking about advanced development and use of rapid and innovative diagnostic tests for identification and characterization of resistant bacteria. Discussion questions. Okay, so number 1, what key gaps or barriers should the U.S. government prioritize addressing to support the development, evaluation, and adoption of new diagnostic tools for resistant pathogens? Number 2, what new diagnostic approaches or advancements for identifying, determining the severity of, and characterizing antimicrobial resistant infections should be considered to create the greatest impact? And number 3, what is needed to better incorporate pathogen and AMR surveillance data along with AI-enabled tools into real-time clinical diagnostics and treatment decision-making? So from here, what I will do is ask that we can answer any of these 3 questions in a similar nature to how we've done the previous questions. We have about 25 minutes for discussion, and towards the end, I will go ahead and say which will be the last question. Again, if you can limit your comments to one of these specific questions, and we will come back to you if you have another thought. Okay, floor is open to the council. All right, Dr. Robin Patel, go ahead.
Hi, thank you. As a diagnostician, first of all, I love this goal. I am going to comment on some of the wording in the goal because I think instead of identification, it should be detection. And I think it's really important for us to be finding not just resistant bacteria, but susceptible bacteria as well. I think diagnostics are a huge answer in the AMR space. I'm biased, obviously, in that. I think a lot of the diagnostics that we use in our clinical practice in medicine are antiquated, and that with new technology, we can do a lot better for our patients. That really the question we should be answering for them is, do they need an antibiotic? And if they need an antibiotic, which antibiotic? Not so much about, putting an academic diagnosis on what it is they have. And with that, we can prevent people from getting antibiotics that they don't need that might be harming them in terms of toxicity, microbiome disturbances, selection of more resistance in them, and even spread of resistance. But what can the government do in these areas? I think any efforts to incentivize the developments of new technologies and help them get through regulatory authorization if that's needed, and if it makes sense, are really helpful. I think supporting implementation science studies where we can show how new diagnostics should be used in clinical practice are really important, because you sometimes have a new technology, but people don't know what to do with it. And I'm not sure it's always the job of industry to perform those kinds of studies. And we've seen great examples where the US government has supported implementation science studies. I think finally, involvement in guidelines is important as well, especially when you have new technologies that come out, because if the guidelines are saying use old technologies, then that's not helping us move along. And then finally, we heard about the cost of doing testing, and that's a big issue on the human side as well. So looking at reimbursement and appropriate reimbursement for diagnostics that are going to help us combat antimicrobial resistance are very important. Thanks.
Awesome. Thank you for those great points. Dr. Kwan.
I love Dr. Patel's comments, but for additional key gaps, I think we really need to address and understand the microbiomes of humans, the environment, and our animals that we both consume and love. And I think the reason why is because these can represent reservoirs, the microbiomes, for potentially drug-resistant infections. To do this, I think we need to invest in the development and dissemination of rapid, scalable, and accurate next-generation sequencing techniques. And these techniques have to be not just academic for scientific papers, but actually being able to bring them to the bedside, whether it be in the veterinary clinic or the hospital setting. And this is not to replace phenotypic testing. Dr. Plummer talked about how useful it is in clinical care, but it's really to be complementary in our armamentarium.
Thank you, Dr. Kwan. Moving over to Dr. Newland.
I mean, following the likes of Dr. Patel and Kwan is difficult, two major experts in these areas. from my side, I think we have to keep in mind, as amazing as the technology is, and as amazing as it's allowing us to see more things, it's also allowing us to be a little bit more challenged on what some of these tests mean. Meaning that some, and as we all know, just because I find a specific bacteria in me, on me, might not mean it needs to have anything done to it, as I think Dr. Kwan has alluded to with microbiome. And so in that, as we get into these next stages, how do we then teach that implementation science around when you use it, when you don't, and how to use it correctly? And sometimes some of these tests maybe don't need to be used, but should be used in the right situation. And I think that education beyond just our frontline clinicians has to go out to families, patients, and others.
Thank you, Dr. Nolan. Dr. Jam.
In agreement with Dr. Newland, and it's just to further supplement Dr. Patel's advisement. I would say when we are developing those guidelines that we emphasize the importance of stewardship, just as we emphasize the importance of stewardship with antimicrobials. I think we have to do the same with diagnostics. The diagnostics are only as good as we steward them and implement them adequately alongside antimicrobial use. So I would further discuss that.
Thank you for that comment. Dr. Wong.
I wanted to mention that along with what Dr. Newland was saying, that not everything is active at the right time. I think we need to do a little bit more precision medicine and interlay the data about the bacteria that we have or the bacteria that we have risk factors for and human features for what is likely to actually lead to disease. And that would allow us to actually not always have to worry about treating with the broadest spectrum just because someone is at risk for having a highly resistant organism. I think we need to also look a lot into expression. Just because the genes are there doesn't mean that we have to treat extremely broadly. And there's very little research that's trying to disentangle those things that I think could be done well if we could mix and match the expertise across microbiology, diagnostic stewardship, clinical epidemiology, and ultimately patient outcomes.
Thank you. Dr. Jenkins.
Thank you very much. Addressing the third point about treatment decision-making. Of course, it would be wonderful to have all the information we need at the time we need to make the decisions, but in reality, that's never the case. We're always dealing with bounded rationality. And therefore, we want to try and understand what information we have available very quickly, immediately, which does allow us to make better decisions. Now, in healthcare, we're very data rich, but we hardly use any of that. If we look at the geographical spread of antimicrobial resistance, certainly in my practice, I know that patients coming from some parts of the city are likely to have resistance levels in E. coli bacteremia, which are twice that of other parts of my area. So just knowing where a patient lives can give me a very useful information, whether I can get away with using something like coamoxiclav, piperacillin and tazobactam, whether I definitely need to use a carbapenem for the treatment of a patient coming with sepsis. That information is basically free. We just need to extract it from our databases. So I think using a machine learning is something which we don't do enough. And using it in a way that delivers very quick information at the point of care is actually very attainable. Over.
Thank you. That was a great example. I appreciate that. Dr. Plummer.
I was just going to follow up and lean into Jam's comments and this concept of stewarding diagnostics. I certainly agree that the genomic opportunities are immense, and particularly once we have isolates and, and for some organisms, perhaps more frequently on the human side than on the veterinary side, if we're looking for CREs or something like that, many times we can find those and know the significance. For some of our stewardship or our treatment decisions on, for instance, the livestock side, where we may be using tetracycline as a first-line drug, I mean, pretty much any metagenomic sequencing you do, you're going to find a tetracycline resistance gene, and that's not good stewardship to say, well, now we can't use tetracyclines just because we found a tetracycline resistance gene somewhere in the microbiome of that patient. And so I think helping to drive stewardship with education and knowledge around the purpose of those diagnostics and how to interpret those results and how that should influence treatment decisions, I think is equally important to the development of those new diagnostics. Over.
Thank you, Dr. Plummer. Dr. Burbick.
I just wanted to sort of maybe put in a plea if there is a big push, obviously new diagnostics, faster diagnosis. I work in a diagnostic lab on the veterinary side, and that would be amazing to be able to get, obviously our results out so people have all the information that they need. But if we're making big leaps forward on the human side, it makes surveillance across these, different sectors more and more difficult. So I would say, trying to keep the veterinary diagnostic side in mind as these technologies are being developed so that we can still be able to compare and be able to work in a One Health space is, I think, really important because obviously we have less funding, less money available to pay for testing, especially if things are new and quite expensive. And so I know it's also a challenge on the human side, but just trying to kind of keep a One Health lens, if we're developing these technologies, how could we use them or implement them in other healthcare settings that are not human, to be able to make sure that we're still able to functionally utilize all the data that we're generating. And I've really struggled in the surveillance work that I do, trying to compare human and animal data just because some of the testing is different, some of the drugs are different, some of the plates are different. How do we trust our data across these different areas? And I do worry that if we are solely focused on human health, that we then are really limiting, the data capacity that we have.
Thank you so much, Claire. Dr. Papich.
Yeah, thank you very much. Central to the questions in this section for veterinary medicine is what diagnostic tools are needed to document resistance. Central to veterinary medicine is simply how do we define resistance? And for that, we need clinical breakpoints. But there is essentially zero funding available to develop clinical breakpoints by CLSI for veterinary drugs and veterinary species. The sponsors of pharmaceuticals have pretty much stopped doing that. There are no new drugs coming on board. And we lack that ability now. For example, we do not even have a clinical breakpoint to detect carbapenem resistance in veterinary animals. So if we're trying to detect CREs, we have no ability to do that because there are no veterinary clinical breakpoints. And the breakpoints that have been developed up until now, at least in the last 20 years or so, were pretty much done by volunteer efforts of just individuals getting whatever data they could. But that effort has essentially been ground to a halt, and I don't see it returning, at least in the near future. So it is a huge gap, and it will hamper our ability in veterinary medicine to advance our efforts to detect clinical resistance.
That is very helpful. May I ask one further question on that? What part of the U.S. government could partner to help with this very outstanding problem?
Possibly the FDA. In fact, actually, the FDA just put out a call for proposals, and the deadline was this past Friday, and I submitted 2 grants specifically to address this. I don't know if it'll get funded or not, but that is probably, at least as far as I can tell, probably the best opportunity that we have at the moment.
Thank you so much. Dr. Jam.
Thank you so much. So to Dr. Jenkinson's point about how we can grab the data and actually figure out those geographical areas that we see resistance, I want to echo again, just re-emphasizing the CDC SBI, which can be very, very integral here and is a tool created by an entity of the government. I say that we continue to optimize this tool, that we continue to place researchers there, that we figure out how we can further refine so that it can be best used for instances of identifying AMR in ways that we can integrate not only therapeutics, but diagnostics as well.
Thank you so much. And I want to challenge the group. I want to hear from Dr. Patel, but I have a question for the group. And that is, as you looked back at the old National Action Plan for this goal, and then are thinking about the current questions that we have outlined, can you speak to a couple of stories of a positive, something that's worked well, whether it's at the One Health cross-cutting lens or the human or animal health? What is one diagnostic story that you think has been supported and has performed well? Dr. Patel.
Oh, I can tell you lots of diagnostic stories. Let me first get to what I was going to comment on, and then I'll give you one story. I wanted to comment on the last point about AI-enabled tools. I think that's critically important in the age in which we live. In our practice, we use AI to read our gram stains and our culture plates, but that's really our data. We need to use all of the data, right? What's in the electronic medical record, along with the laboratory level data to figure out, for example, who needs what test and when, and how that test really should be interpreted. I know there were questions about that as well. And all of those are now possibilities. They will jive well with diagnostic stewardship, getting the right test for the right patient at the right time. So I think that's really important. There are lots of success stories. I'm the laboratory center director for the ARLG, and we've executed several implementation science studies looking at the value of new diagnostics to appropriate use of antimicrobial agents and patient outcomes. And we have brought new diagnostics to regulatory authorization through support from NIAID. So tons of successful stories on bringing diagnostics that help with AMR. Thanks.
Thank you so much. Yeah, I want to highlight that group has really helped achieve some of the goals from the previous National Action Plan. Francisco.
Yeah, thanks for that. I wanted to piggyback on that same point about AI and also surveillance data. I suppose there are examples, including from our group, trying to understand how the large-scale surveillance data, such as NARMS, can help inform then picking the right markers for virulence. For example, for Salmonella, we know that there are specific markers that have been hard to pin down, but once you pair that with actual surveillance data on the human side, you can start teasing out which ones actually matter. So in terms of AMR stewardship, antibiotic stewardship rather, even if we don't necessarily target AMR, knowing which pathogens actually will make a difference. Again, going back to Salmonella, something like Salmonella Kentucky, the one that is predominant in the United States, is probably not going to progress into an aggressive infection as opposed to, say, Salmonella Dublin, right? So diagnostics that can tie those two pieces could be quite useful. But again, the rapidness to make a clinical decision, that will be the next frontier, I think, for you guys in clinical practice.
Thank you. Do I have any takers on any further comments on some of the questions that we have listed here? We've talked a little bit about AI. Does anyone want to speak on what new diagnostic approaches or advancements for identifying, determining the severity of, and characterizing antimicrobial resistant infections should be considered to create the greatest impact? Dr. Patel.
Yeah, I'm happy to comment on that. I think because physicians in medical practice are making decisions on use of therapies, speed is really important. So getting to answers quickly. And I don't want to comment on one technology because there's so many technologies now, right, that can provide really rapid, in a matter of minutes, answers as to is this patient sick enough to need therapy now? Therapy, and we need to that. So we're not using antibiotics empirically as much as we have historically, and we really get to that diagnosis. And that also gets into prognostication. A lot of times we work in the moment about what's going on now, but we really need to be thinking about what's going to happen to this patient. You know, if I don't do something today, what's going to happen to them in a week? A lot of patients will get better on their own without treatment, right? So we need to find the ones who need us to intervene today, now, and with what. And I think there are a lot of rapid technologies that can do that. Of course, you know, as has been mentioned, we need the technologies first, and then we need to figure out how to use them through implementation science studies. But I think sort of that pathway is well laid out today.
Yeah, that's great. Thank you so much. Dr. Plummer.
So as I think about these advancements that are needed, particularly on the One Health side, I think you know our diagnostics in crops and food supply systems outside of NOMS, you know, doing some surveillance or NARMS doing some surveillance and those types of things, but certainly improved diagnostics in those spaces are direly needed to help make quick, rapid decisions that are going to influence not just treatment of one plant, but of, you know, thousands of plants or multiple acres. And our diagnostics, at least on-site diagnostics, are almost non-existent in that sense. I would say on the livestock side, people have talked about the cost and certainly diagnostic labs being supported, but cost is a major driver. And you know, I've said before on PACCARB meetings, if it costs $250 to do a antimicrobial susceptibility test, when I can prescribe a drug for $5, it's really hard in the absence of you know, CMS driving those decisions or reimbursement decisions when there's no you know, insurance covering that. So rapid, fast, on point of care diagnostics on both the livestock and crop side, I think, are areas we need a lot of advancement in.
Very helpful. Thank you. I'm going to go to Dr. Wong.
I want to just comment on the way that the goal is phrased. I think it's, and we focused a lot on advancing development because for the longest time we didn't have enormous movement in that area. But I think just like Dr. Patel and Plummer mentioned, after development, there is a huge host of investment that needs to be done to talk about how, in fact, we deploy it in whom. And again, now in this world where we have a lot of data, trying to understand the value in certain populations, both from an economic point of view, but also prognostication value is really important. And the investment usually stops after it's been approved and released. And I think that nationally and internationally, we need to continue to invest in answering those critical questions so that things that are created with all the effort it takes to bring them to market can actually be used in the best way, including broadened for bigger uses.
Thank you. Dr. Burbick.
Yeah, and I'm not sure if this is totally the right place, but I think so. One of the things that I think we overlook and maybe kind of group them in environment, but maybe in veterinary medicine is providing diagnostic innovation and support around honeybee health, as well as our aquatic species. We have some kind of difficult pathogens to diagnose in some of these, and we use some testing that could probably be advanced quite a bit, dealing with honeybees where we do use antibiotics, as well as in fish and aquatic species. But you know, because they are have pathogens that might be somewhat difficult to culture, or are very slow growing, et cetera, I think those two areas could really deserve some attention as far as innovation around testing and test development, because we definitely are using drugs in those spaces. Also, especially for aquatic species, they're getting huge impacts from things that are coming off the land into the aquatic environment. And so are also kind of at risk, for other reasons. But I think are a very underserved area where test optimization or innovation could happen. And I think, at least on the veterinary side, there are state diagnostic labs that are trying to work in this space. And I know USDA has labs focused on honeybee health, but I think these are also areas that are sorely lacking in support for testing, not only from the innovation side, but also just money to be able to do it, which has been mentioned multiple times on the vet side, is quite expensive for people to pay for this. And I really think it needs to be stated explicitly in these sectors.
And can I ask you again, for what government agency or what would the U.S. government which part of the government would potentially be able to help with this topic?
I think both the USDA and FDA have roles, one from the drug side and one from the agriculture side, obviously. So, I know, at least in my experience, we in the D labs get support from both the USDA and FDA to work in this space. And they do partner and have partnered, I think, pretty effectively across AMR surveillance. And so I think the USDA, FDA, would be really good partners to support this work in kind of these more niche areas, but I think important areas, especially when you see, for honeybee health, how that's impacting crop health in different, sectors across plant agriculture as well. So I think there needs to be more attention and more effort there, and I think the USDA and FDA would be good partners.
So incredibly insightful, Dr. Barbeck. Thank you, as always. Really appreciate it. Dr. Kwan, and then I think we will maybe end with Dr. Jenkins after that.
So I'm going to think ARPA-H style here, but just thinking about the future state and personalized medicine, which people have been dropping hints of, and AI, how impactful would it be if we had diagnostics that could predict the impact of a particular antibiotic on a person or animal in terms of the collateral disruption to the other microbes in the body? So not just for the UTI, but what happens to the gut, what happens to the skin microbiome, et cetera. So for instance, we know that specific antibiotics can increase the risk of C. diff in individual patients, but what if we had tools that can individualize our choices to give treatment plans that would either predict or mitigate this risk? So I think if we can work on the development and invest in of these sorts of diagnostics to measure this disruption idea, likely using AI to help, this could be something that could really revolutionize the way we care for our patients and animals. So pie in the sky, but I wanted to drop that.
I appreciate that. I also feel like that could be communicated in a way to show impact that might get to some of goal one as well. Dr. Jenkins, you're going to end us off on this topic.
Thank you. I predict over the lifetime of the next National Action Plan, there will be substantial advances in the development of diagnostic tests that focus on patient reactions to infection, immediate reactions, which allow, for example, a differentiation between bacterial and viral infections, which are very useful deciding whether or not to give the patient antibiotics. One of the challenges I suspect that might rise is that these will not be tests that normally fit into, or currently would fit into, a microbiology laboratory. They are not growing the organism or detecting the organism. And I wonder whether or not that's going to be a barrier to taking up these tests, because they don't naturally fit into a kind of pre-existing diagnostic modality. For example, should biochemistry now become infectious disease diagnosticians, for example? And I think that's something we need to be aware of and provide some kind of guidance to laboratories to take up these tests. Otherwise, we risk losing the advantages these tests potentially offer. Thank you.
Thank you, Dr. Jenkins, and thank you to the Council for your insightful input into Goal 3 of the National Action Plan updates. I'm now going to turn it over to Dr. Lynn Marks for Goal 4.
Thank you, Dr. Patel. Very interesting session. Thank you.
Yes.
I'm going to try to do something different here. This may be a mistake, but maybe we'll learn from it for future meetings. I'm going to go through each question and make a comment personally about each one, and then I'm going to open it up to the group to comment on as many of the questions as you want, because I think my colleagues have been very well behaved in terms of succinct comments. So maybe we'll try that, and maybe goal 5 will go back to the other way once we find out this is a problem. Anyway, goal 4, accelerate basic and applied research and development for antibiotics, other therapeutics, and vaccines. The questions, and I think if we look back at the 2020-25 action plan under goal 4, also the other goals, but particularly in goal 4, there was a lot of great questions, comments, thoughts, ideas, and concepts. But here we're being asked to come up with the top 2 to 3 whole of government priorities and initiatives under this goal that would have the greatest near-term impact. I think for me, the greatest near-term impact that we could do would be to define leadership and scope. When multitudes of groups are responsible for actions, no one is in charge. I do think we need to go back to that idea of identifying an individual or an organization whose job it is to connect and pull together across the government in terms of the priorities and how we're going to go about doing those. And then the scope, as I mentioned at goal 1, connecting rather than dividing. So sepsis being a classic overlap with AMR, hospital-acquired infections, healthcare-associated infections, infections in the warfighter, biothreats, et cetera, et cetera. There are islands that are competing for resources where if they were collective, maybe the impact on morbidity, mortality, and the economics would mandate more direct funding, et cetera. Our question 2 is, what key evidence gaps or barriers should the government prioritize addressing most effectively, accelerate the research, development, evaluation, and sustainable access to prevent and treat infections? You know, I think we've got massive amounts of evidence from international groups, the US groups. I think there have been tons of publications as to what the evidence is that we need to effectively prioritize more R&D for a broad spectrum of solutions. But one of the biggest barriers remains the economics of the model. Healthcare professionals aren't going into the area. Investment community is continuing to look the other way, with a few notable exceptions. I'll point out the AMR Action Fund, just because we have Dr. Skinner here. So thank you for that. It's a theme of novel models trying to address new ways of doing things. But we're in a situation where overall we are less well prepared today than we were yesterday. And if we continue on the same trajectory, we will be less well prepared tomorrow than we are today. I don't think we're going in the right direction overall in this space. And then our third question is, for domestic manufacturing, how can the government maximize existing resources for domestic manufacturing capacity of critical and other antibacterials while maintaining affordability and quality? Good question. I mean, I think it's a national security question actually as well, and not just health security, but national security in terms of our dependence on others for key medicines, including antibacterials. And the theme of different models, one that comes to mind, and I have no ownership, interest, or otherwise, I just have an awareness of Civica, which is a group that produces antimicrobials across a buying collective with multi-year contracts that are bought into, and they're on a not-for-profit model within their collective of stakeholders. And the question in my mind is, are there areas where working with generic manufacturers, models like and different from Civica, but are there other ways of thinking about this in terms of our key needs in antimicrobials? So I'll stop my oratory there and open it up for questions. comments, actually. Did I stifle everyone's ability to comment? Lucas, I think you popped first. Thank you.
Yeah, coming to the rescue, Lee. So
Yes.
very brief, addressing the gaps, and I think focus on veterinary medicine. You know, we seem to have a maldistribution of veterinarians with decreased number of new graduates who want to go into the rural areas where they are, you know, high risk areas because, as we learned from high path influenza outbreaks in those areas, you know, and I think having veterinarians that they're the first responders a lot of times is key, especially in rural areas. So how to address that gap by incentivizing new graduates to go into those underserved areas would be a key to improve infection prevention and control and early detection.
Thank you, Lucas. I think, Jason, you had your hand up next.
Yeah, thanks, Lynn. Thanks for your comments and leading this section. Top priorities. For me, at this time, I think number one, we've talked about for ages is new antimicrobials, whatever that looks like. We've talked about Pasteur Act throughout, and you mentioned this, the incentives and such that just aren't there for companies to keep developing. Where do bacteriophages come? Where do novel sort of therapeutic approaches come? If we don't keep researching that and continue to advance and think others ways of doing that, we will fall behind. And many of us have already felt like we've been behind in caring for a patient that has a bacteria that's resistant to everything we have in our armamentarium, and then we can't use it. Number two is vaccines. I think that the development of better vaccines is necessary. I think I was just talking about influenza and the fact that we don't have the best vaccine for influenza on many respects, that we have to get it annually, that it doesn't hit everything. And we know it's not going to do those things. And we need to continue to make sure that our vaccines, especially these new ones, are safe. Pertussis vaccine would be great to have a better pertussis vaccine. I think these areas we know work in prevention, and we need to continue to advance those and research them, research new ways of doing this. And that has to be continued to be prioritized.
Thank you, Jason. Yeah, I'll just build on that briefly in terms of running out of antibiotics in general, but it's also like if we find one new antibiotic that's going to be effective for everybody, they're going to be able to tolerate it, it's going to be okay. We need multiple options across different patient populations with underlying diseases, et cetera, et cetera. So I worry that we focus on one or two, and that's our objective and our goal. I don't think that's adequate. I think, Paul, you were next.
Yes, and at the risk of sounding like a broken record, as I think about the top and perhaps the wording of this question, but the whole of government priorities, I think PACCARB, we've talked multiple times today about the huge benefit that those One Health approaches brings to this discussion. We've talked and are getting these questions from the CARB task force, which is a multi-agency, interactive opportunity. I think one of the biggest issues that's slowing down near-term progress on the research side is a whole of government approach to One Health AMR research. I recognize the complexity of that, crossing, as I mentioned, the scopes of many different funding agencies and priorities, but we're putting into action in PACCARB and the CARB task force that concept, but we're being held back by a lack of a funding agency with significant funding to accomplish the work of a large scope One Health project. And so I think that is a whole of government priority or initiative that could be explored.
Thank you, Paul. Dr. Patel?
Yeah, I'm going to respond a little bit to sort of the wording and structuring of this goal like I did with prior. goals, I saw it as we need new interventions, we need new therapeutics, and we definitely do. And I agree with what others have said, that you're talking about a multitude of different clinical syndromes and a multitude of different organisms. We actually probably need better therapeutics, not just for bacteria, but for viruses as well. And that might help actually with antimicrobial resistance. And then I was a little confused because it points to what are the two whole of government priorities and initiatives. And that's a little scary for me because I think we actually need many. And maybe this is just so high level that there are several underneath those. But there's so many possibilities. We're looking at the exit of pharma from development of new therapeutics because it's not financially rewarding, and there are other areas that are. But in infectious diseases, we clearly need new therapeutics. And so it's a little scary to see two or three priorities. And then I know that manufacturing is a problem, but to have that, built in here also detracts a little bit from we need new and better therapies, not just antibiotics, but as mentioned, non-antibiotic approaches as well for, again, a multitude of infectious diseases.
Yeah, thank you for that. I'm sure I'm a pathological aggregator, but I like pulling things together rather than separating them out. So viruses, fungi, I'm a equal opportunity, take care of the patient kind of person, not just which pathogen is on a list. Prioritization I get. Thank you. Dr. Kwan?
I think an immediate top priority needs to be workforce. So to do any of this work that we're all talking about, it really requires investment in medical veterinary doctors focused in infectious diseases, biosecurity, public health, and researchers. It's been touched upon, but we really need to keep this pipeline of people doing the research in this area very strong at every level, not just at entry, but the people who are doing it now as well. We need to keep them engaged, interested, and keep doing this work because it's incredibly important. Thank you.
I think, Jacinda, I think you're being referred to as Dr. Jam. Is that your preferred?
That's perfect.
Okay.
It is. Such a
you.
nice acronym I got, courtesy of my husband. But yeah, so I think that to Dr. Kwan's point, all of these things and all the therapeutics and so on is important. But in supplementing the workforce, I want to re-urge the connection of non-communicable diseases and communicable diseases for the whole public. I think a lot of times the conversation for AMR lies squarely on the shoulders of the infectious diseases professionals. But I think it is a conversation for PCPs and so on and so forth to also be a part of. So by connecting that, hey, if you have a cardiovascular disease or if you have diabetes, it makes you more susceptible to an antimicrobial resistant UTI or so on. So this is why, we need tighter control for that. And I think even with vaccinations, this will help us as we are using those vaccines to target those folks that are our priority to ensure that we're starting there in terms of AMR.
Thank you so much. Dr. Jenkins?
Yeah, thank you. I'd like to address the question about domestic manufacturing. And I think whilst it's an issue for the US, it's also an issue for virtually everywhere in the world, because there are very few manufacturers of pharmaceuticals, particularly of the active pharmaceutical ingredients, the APIs. And these are critical to the finished products. And you could, in the US, go down the route that the European Union is going through with the Critical Medicines Act, or alternatively, more internationally, recognize that this is an international problem and develop an international response to that, developing robust networks of API manufacturing so that we are not held jeopardy to one factory going offline for whatever reason, and then the whole world suffering a shortage of really important generics. I mean, people are talking about new antimicrobials, for example, cefiderocol, ceftazimab-avibactam. They make up less than 0.01% of prescribing. I think the straightforward antimicrobials, amoxicillin and so on, the basic penicillins are really critical. And yet they are sunset industries, and we need to be very careful that they don't be extinct. So I think an international response, so it's kind of preempting goal 5, but I think that's something that we should be addressing globally. Thank you.
Thank you. Dr. Papich?
Yeah, I just wanted to point out that in veterinary medicine, when we're talking about new therapeutics, we will not see any new classes of antibiotics for animals ever again. The WHO has already said that any new classes of antibiotics should never be given to animals. I realize that US is not involved, is pulled out of the WHO, but nevertheless, the veterinary pharmaceutical companies that in the past have developed new molecules. They do have some new molecules, but they're never going to be developed for animals. That pipeline is shut. It's closed. So the only alternative we have left for new therapeutics, other than what we are already using, of course, human antibiotics in our companion animals, but other than that, we're going to be left with new technology, new non-antibiotic options that have already been mentioned, compounds to change the virulence or other opportunities that may come up. So we're going to have to focus on that, at least in veterinary medicine.
Yeah. Yeah, I think it's, I don't actually even know any clue how to address that gap, because if you're not going to have any new antibiotics, or with all due respect, very few new antibiotics, and we're going to rely on that supply to take care of people and flow down to the animals. I don't know how that's going to work ultimately.
Yeah, well, it's for the resistant infections that we see, whether it's ESBLs or methicillin-resistant staph, CREs, we have no approved antibiotics for those indications. We have to use human label drugs, extra label, and in some places that's restricted or certainly discouraged.
Yeah. Yeah. And I think, going back to the economics of it, because to me, that is and I don't think that's a near-term thing, is why I didn't put it under the first question mark as to the whole of government near-term thing. I don't think that's quick. My career has been spent watching initiatives fail in terms of economic incentives. I worked in infectious disease R&D most of my life. So I've watched this space progressively collapse. Some models are popping up in different parts of the world. I have not seen the US do much in terms of leadership. I say that with all due respect, because I think people in the government are really trying and care and want to get together, but there are many, many challenges to overcome. I see Casey smiling there, so maybe I'm not totally out of my tree. I'm not sure how to do it. I don't want to be pessimistic about it, but I'm looking for rays of hope. CMS did some stuff in terms of working a few years back. I don't know if that's progressing or not. I'm not close enough to it anymore. And I know that without that, maybe I shouldn't put Henry on the spot, but just thinking about our pipeline, I don't know if you want to say a few words.
Yeah, I over the past 6 years running the fund and trying to lead investment into the space, I think the pipeline is declining in both quantity and quality. The underinvestment that has now been going on for decades, conspires to have companies try to advance as skinny as possible and to avoid difficult things like CMC, process chemistry, manufacturing, formulation, and other things that are critical if we're to bring these new drugs and formulations to patients in an effective way, let alone develop a robust set of clinical data to inform physicians as to how best to use it and what indication. And many of these companies are so strapped, they're lucky if they can get a drug approved in CUTI, let alone explore it in HAP/VAP and intra-abdominal and other areas. So without data, how do we drive the proper utilization, let alone anything else? We can repeat the same thing with diagnostics, which is similarly challenged. And I think, to your point, unless we in government collectively solves the problem of a market that's dysfunctional and doesn't reward innovation, we simply won't have any, and it will disappear across the globe, and this problem will continue. We won't get new antibiotics. Maybe we'll get some new antifungals. I think that's a bit of a different market, but to your point of the different indications, the different pathogens, the different patients, we need multiple successes here. And we need to find a way to to understand the long-term value that a new antibiotic brings to public health that we've not yet recognized. So things like PACCARB are going to be essential. There's other things we could be doing in intermediate on reducing some of the cost and barriers. And I'll just exemplify one as we think about trying to reduce the cost of post-approval. We in Europe both require post-approval pediatric studies, and yet they're not the same, right? These sort of duplications unnecessarily of expenses really make it prohibitive for companies to try to broaden the market and leverage things. So I think that's something we could begin to address across the globe more efficiently, and also look to drive access more equitably at the same time.
Yeah.
And the last point, we talked about some of the human talent and training challenges. The innovation ecosystem is unique and requires a very unique set of skills in chemistry with beta-lactams and beta-lactamase inhibitors and other things that does not necessarily translate easily. And as big pharma's left the space and disrupted those scientists, as the SMEs are underfinanced, we're not training the next generations of talent here. In fact, we will be losing know-how across the spectrum to be able to execute. And I'll just give one example. Acinetobacter, as it began to rise 25 years ago, it took us 19 years to get the first antibiotic approved with Acinetobacter on the label. Right, so these aren't instant things, and as the human talent continues to decline and we don't replace it, we're putting ourselves at a great detriment. And I would add the training of microbiologists, even if we think about the potential for the microbiome on a number of fronts, both as preventative as well as treatment from C. diff and other things. We're starving our talent and the innovators of the ability to progress here. I don't want to be too negative. I think there are things we can do, like PACCARB, like some of the regulatory harmonization that can be meaningful, and aligning activity in government that does support from NIH to ASPR and BARDA, across that continuum to make sure that we are investing in the most promising opportunities.
Yeah. And I'm a big fan of incentive models like PACCARB. My cautionary note is I don't think that's going to be enough. And my worry is that the government will say, hey, we did what people wanted. We passed this act and everything is going to be rosy. I don't think the world works that way. But anyway, that's me. And maybe I need to cheer up here. Jason, we got 2 minutes.
You're a happy guy, Lynn. Don't sell yourself short. Henry, and this has been brought up by others. I do think your highlight of the lack of maybe young people going into our fields is a problem. And I think if you take it from, and I want to say this across our fields, and when I say our fields, I'm saying from the PhD scientist to the veterinary medicine to the microbiologist to the physician, to the nurse practitioner, you name it across. And then on top of that, the scientists within those who cross maybe a multiple of items, whether it's the veterinarian who's also in their lab or the physician who's also in their lab or in these other places. That is important. And from my own setting as a pediatric infectious diseases physician who recently heard from our American Board of Pediatrics, we're going to decrease our fellowships to 2 years because we're running out of people. And that's across subspecialties in pediatrics. So that's a bigger issue. But there is the concern that you will then lose those scientists within the group who would provide maybe those incredible innovations that have come, right? I mean, I think of these people who have done amazing work to develop the next vaccines or the next antimicrobials because it was that one patient. That doesn't have to be just for the physician, but that could be for anybody on this or in the future. So Henry, I appreciate you bringing that to light. And maybe that's probably a bigger part is how do you invest in the youth to inspire the next innovations that will change the world. And that's high in the sky and pie in the sky, but I think that's how you have to think. So thank you for bringing that up, Henry, and Lynn for letting me go on.
Thank you, Jason. Paul?
Yeah, I was just going to add to Jason's and Henry's comments. I think that workforce development that's been mentioned a number of times is huge, and I do think that extends through all of those fields that Jason talked about, but it also extends into government and policy and the agencies, to help guide that research, guide those priorities, and recruiting young youth into those areas of the federal agencies, research funding agencies and stuff, I think is important in that continuum as well.
Yeah, thank you. Dr. Wong?
Listening to all the comments, each thing seems so enormous, with a lot of issues to untangle. And so I just wanted to reiterate the comment in the beginning that it is really helpful to have a singular appointed person whose job is to think about how all of these things can coalesce and how investments can be made to really impact the many, many things we've all have raised.
Yeah, I agree. I think, if I did try to be optimistic for, 30 seconds, I do think we have the capability to change this. We have the capability collectively to change the trajectory of where it is. And in my opinion, it is getting worse and worse, not better and better. And I hope we can do it before there is some major problem that is a catastrophe. We need a change in mindset. We need a clear leadership, and avoid that situation where it's just rampant, where we can't do cancer therapies, we can't do transplants, we can't put artificial joints in people, we can't improve the quality of life. Those are avoidable, in my opinion. We have the technology, we have the capability, but we don't have the connected, aggregated, integrated, collective will and funding to move in a direction. And I don't think this is a U.S. only problem to solve. I think this is going to require international involvement, international capabilities, collaborations, and trust, and novel ways of doing business. And we're going to have to make it a business to keep our population healthy. And if we can't manage infectious diseases, we will not be able to keep our population healthy, or our warfighters, or our whatevers. It's just, it's a national security, it's health security, it's a global challenge. I'm sort of at the point in my career where it's winding down rather than winding up, which is why I'm worried about the youth. I got 4 grandkids and 4 great-grandkids. I hope all of them go into something to do with making the world better. And what a better place than working on the challenge of AMR. Lucas.
Yeah, just kind of following on what Dr. Papich was saying, that, the fact that in veterinary medicine, we are not going to have any new antibiotics, and what we have now is what we have. That thought and the fact that I'm trying to be a good steward has changed the way I practice, at least in the clinic with small animals. For example, to me, skin infections or abscesses are not an antibiotic treated disease for the most part. I rely either on surgical technique, drainage of an abscess and lavage, or topical alternative therapies to treat some of these topical infections. So, 90% of my patients are not treated with those diseases with an antibiotic, while we'll still have a lot of veterinarians that rely on long-lasting third-generation cephalosporins to treat those type of diseases, which is, an overuse of an antibiotic that is high critically important in human medicine. So I think we need to probably change our mind and realize, the antibiotics that we have is what we have for now and the future. So we need to change the way we practice and educate the new generations and the older generations that are practicing veterinary medicine at this time.
Yeah. And thank you for that. I've never worked in the diagnostics business, but just thinking about it and talking to people, I think the economic model there is probably even more dire than for therapeutics, and therapeutics are abysmal. So for our colleagues in diagnostics, hang in there. I think the technologies are cool from what I can tell. I think they have a lot of promise, incredibly important in this space, but the economics I worry about. So maybe with that, I'll thank everybody for allowing me to change up the way we did it, and hand over to Francisco for the final goal.
For that, Lynn, and I guess there was quite a bit of segue to this session because we heard several times mention of international collaboration, international efforts, and in fact, several of the members here are from international organizations. So it's a nice transition to goal 5, which is improve international collaboration and capacities for antibiotic resistance prevention, surveillance, control, and antibiotic research and development, which is very, very large scope indeed. So I think I got my job much easier now thanks to our prior 4 sessions. I'm going to be very open to how you interact. Clearly, there are a lot of things that each of us have to comment on these, and these are only 3 questions which I will read out loud, but we could spend hours talking about this. I think the first one is very, very key. How can international dimensions of the PACCARB National Action Plan strengthen domestic efforts? And of course, we all are aware of the plan and how it will change, but I think fundamentally, this gives us an opportunity to revisit that and how we can really be a bit more centered on domestic efforts while also collaborating abroad. The second is what core international AMR capabilities, e.g. labs, surveillance, data systems, workforce, infection prevention, regulatory capacity, have been under-addressed in prior U.S. national action plans for combating antibiotic-resistant bacteria. And then the third is what accountability structure should be embedded to ensure sustained progress. Are there indicators of U.S. international AMR efforts that would be especially impactful to track? I think that last one is very key. You have heard me before talking in our prior meetings about metrics, having a common language to understand how we're doing. So I'm very interested in your thoughts on this. So with that, I open it up to discussions. Dr. Patel.
I'll just kick this topic off at a very high level. I think we all know this, but it's important to recognize that microbes know no borders. They move across the world. And so what is happening in other countries is really relevant to the United States, because almost certainly if there's a type of antimicrobial resistance somewhere else in the world, we're going to see it here. And so just knowing about that and understanding it is important. Also, at least as a scientist, it brings lots of questions. How does that type of resistance work? Is it going to spread to humans, within animals, in the environment? Where did it come from in the first place? How do we treat it? Those lessons are being learned in other countries where different types of resistance are emerging or more common than in the United States. And we really need to have, good intelligence understanding what's happening there, because it's going to come to us at some point, inevitably. So I'll just lead. I know that's really high level, but I think it's important to recognize.
Thanks for that comment. And of course, we have had in the past mechanisms to collaborate internationally to track those, some of those emergent pathogens, and now we have a bit more restrictions to that, and at least from the U.S. perspective. It's a quiet end of the session, and I'm surprised. Okay, Dr. Whitten, please.
I guess as I was looking at those questions, the thing I was thinking about is how many, probably any of us has had the experience of traveling in a less developed country and going to a lab, at least on the veterinary labs, we see it, and and some international organization has bought a MySeq and a Kingfisher and a Multi-Toff, right? But the person who's trained to use it got a promotion 3 months after they got the equipment, and there's nobody else there who can run the equipment, and so the whole program that equipment was expected to support has gone by the wayside. And so it just made me think about the idea of workforce development, which we're talking about, very important in the US, but also internationally. If we want to address some of these AMR problems globally before they come to us in the US, then buying equipment and workforce development in those locations is going to be the way to do that. So ongoing training, whether it's train the trainer or some type of programs to support continued workforce in those to address the problems of AMR globally. That's all.
Thank you, Dr. Whitten. Dr. Patel.
Yeah, I think I would support those comments. I've been involved with some work that looked at antimicrobial stewardship and infection prevention capabilities globally in the post-pandemic world. And I think that workforce has been not just an issue domestically, but really internationally. And so even supporting the US workforce in return could really, I think, help with some of these global issues. The second question that I'll address is what I think it's the first question. How can international dimensions of the PACCARB National Action Plan strengthen domestic efforts? Again, I think we're hearing a theme of, things that happen here happen there, and things that happen there happen here. And so I'll give one example, and the CDC has worked on assessing quality of antimicrobial stewardship programs in countries outside of the US, and that is now being developed and used as a tool in several other countries. And so I think continuing to invest in ways that we think are important here. We've talked about assessing quality of antimicrobial stewardship programs in the US. Those tools can then be used on the international setting as well. So as the CARB task force thinks of some of the comments that we've made today, thinking about how some of those tools can be used in different settings, I think can be really helpful.
Thank you for that comment. Very, very, very insightful indeed. Dr. Plummer.
I was going to add that I think one of the issues that's come up a couple of times in the various questions today is definitions, comparability of data, those types of things. And so particularly in this space, I think that we need to build our action plans and pursue our research really with a focus around understanding and trying to assure that when we're aggregating data from multiple countries, it's comparable, it's kind of based in the same metrics. So across different countries, we have different breakpoints potentially being utilized. We've got Kirby-Bauer or e-test or broth microdilution. And in so many cases, there's efforts to aggregate this data, but they're not pulling data that really is comparable even across one health species where we have different breakpoints in humans and animals. And so I think that is a component that we need to continue to focus on as we seek to evaluate differences and outcomes across country levels where there's very different data collection methodologies, definitions, and priorities.
Thanks for that, Paul Wolf. Yeah, I've been for years trying to do basic compare risks and antimicrobial resistant risks, and not just AMR, but actual illnesses across countries. And I can tell you, it's close to impossible for all the reasons you mentioned, plus some others. Like, for example, when we talk about surveillance systems, some systems have better detection than others. If you have a country, say like France or the United Kingdom, that has a nationalized healthcare system versus our more fragmented system, that creates big challenges, even if everything else was equal. Thanks for that. Dr. Marks.
Yeah, thank you. I was just looking at the second question on core capabilities that have been under addressed in prior plans. And is almost like a clarification of that. Under addressed in terms of writing down a recommendation, or under addressed in terms of actually being implemented? Because for me, over the years, PACCARB, National Action Plans, we've put out, I don't know, PACCARB's probably put out hundreds of recommendation. I have no clue how many of them have been acted on in any way by anybody. Or is anybody being held accountable for something they said they were going to do or not? Probably an impossible task to go back and look at what they've done. But for me, there's no lack of recommendations here. In fact, my worry is the opposite. When we tell the government 500 things to do, that's almost like giving them permission to do nothing, because it's overwhelming in terms of how are we going to do it? Where does the money come from? Is it an unfunded mandate? I mean, all that language that you hear piles up. So I'm gonna reject the premise on question 2 in your section, Francisco.
Always with the thought-provoking comments. Thanks for that. Dr. Waterman.
Hi, I wonder if I might echo a comment that one of the Dr. Patels made, I think, with the first goal, which was to talk about coordinating, or I think she said funding efforts across government agencies. So recognize in the department in which I sit, we continue to have a presence internationally. And since I reside in sort of the health world, we do continue to have surveillance for very AMR, among other things, right, that as it impacts our military. So we remain a viable partner, both as already receivers and collection of surveillance information, but also it gives you that node of some of the places we are, of what's going on abroad. So that continues to be, I think, of value. And then the other thing, I was trying to figure out which discussion question this fell under, and I'm supposed to only have one, was, we've seen some of the surveillance work with, viral pandemics at sort of ports of entry into the country. And that is, I mean, we import food, I don't know that people travel. Maybe that's another place to sort of think about getting surveillance information in a way that we hadn't done before, for the purpose of, broadening what's coming in from outside, so that we can sort of have a handle on what we might see as an uptake in our, healthcare systems writ large. And I mean, human, veterinary, and potentially environmental. Thank you.
Thank you. And I'm sure you're going to butcher your last name, Dr. Simsak, please.
That was actually quite good. So my comment, it echoes a little bit about what we've already heard, but it addresses the first question about how international dimensions of the National Action Plan can strengthen domestic efforts. I just want to emphasize the importance of bidirectional learning. I was involved, as well as Dr. Payal Patel, in this global antibiotic stewardship evaluation tool work that the CDC led, and partnered with people internationally to help develop and validate the tool. And I think that, again, thinking about stewardship happens everywhere, and it's implemented across contexts with varied resources. And that entire project, taught me a lot about how we can think about adapting stewardship interventions across the kind of places where care is delivered in the US. So I just want to emphasize that there is a lot of value in bidirectional learning, research across contexts, that we really benefit from a domestic perspective. Thank you.
Thank you, Julie. And if I can add a little bit of that from my personal perspective too, I think we often focus on collaborating with, say, Europe and other basically high R&D effort countries, but the return investment of collaborating with also scientists from LMIC countries is huge. Very little improvements can be done on a day-to-day basis with, say, a researcher from France or Canada. But huge improvements in stewardship and resistance can be achieved with much less effort in LMIC countries. Again, that's my personal perspective. Thank you. Dr. Kwon.
So I want to comment on the international dimensions to strengthen domestic efforts. As I understand, many antibiotics, as many drugs are, have split chain models where raw materials are made in perhaps one country, and then the antibiotics are imported, or the materials are imported. The final products are then made in another country. I think we need to really focus on the supply chains both locally and globally, and the relationships we have with these other areas and countries that are making these raw materials for the antimicrobials, so that we can ensure the security of our supply chain here. I think the PASTEUR Act in some ways gets to this, especially with increasing the pipeline of new drugs, but I think we also need to focus on the existing drugs as well.
It's a very insightful comment. I wonder if members here, perhaps Dr. Marks, Dr. Skinner, might have thoughts on that, on the supply chain aspect.
Go ahead, Henry. Start off.
Yeah, it's a real challenge. I mean, if we think about the basics, just fermenting penicillin, we're down to a few places, and there's some attempts to re-onshore that in India and Japan, and we should think about it as well, but it needs to be efficient and coordinated. As I look at the new companies, it's a huge problem as we look to the manufacturing and the formulation. The few places who can even work with some of these substances makes it uniquely challenging as how to do it. There are very few choices for most of the SMEs to access, period. And it's a growing problem with fewer and fewer suppliers. And I do think we need to think long term, how do we address it from the most, from augmentin on up to the latest things. And cefiderocol is very complicated and challenging to make. But we're getting to the point of, and we've seen shortages that I think reflect these challenges, and the fact that you end up with the sole supplier and effectively no solution. So I don't have an answer to it other than to say we probably need to find a way to have some redundancy in the system, which means we're going to have to pay $6 and not $5 for a basic script.
Yeah, I don't have anything optimistic to add in that either. I mean, even if you just take simple penicillins, I mean, they're dedicated facilities, and so it just keeps compounding on and on in terms of the challenge of it. And a sole source supplier, I was trying to remember the example of, I don't know if it was Puerto Rico, I don't remember, but we've had classic examples of where facilities have gone down and we've lost products because of that. I don't know why we need to learn that lesson again.
Thanks for those comments. Dr. Juan.
I wanted to speak to the second bullet about core international capacities. One of the strengths of humans is that we are different, and there's different cultures, there's different approaches that occur across countries, across states. And I think that we could really use some knowledge management. We rely on our publication record, but so many things are not in there. Even those that do publish, they are focused on the outcome, not why it worked, not necessarily all the details, all the lessons learned, all the mistakes, and all the wins. And I think that we really should capitalize on the hundreds and thousands of things that people are trying to try to better understand how we don't have to relearn complex lessons, and how we can put certain infrastructures in place, even with low resources, because someone already learned that lesson how.
Thanks for that. I wonder if you could give us an example of some of those resources that maybe are not publicly published, perhaps, but might be insightful for us.
Well, so a big one that I can think about is approach, right? So different cultures have different ways in which they believe, for example, population health is really important versus, my health is important. So the way you speak to someone, the way you publicize something, the way you put something on the wall could be really, really different and well received in certain populations versus not. So that's a really easy example about needing to learn about how different people learn, adapt, and appreciate camaraderie. But it can relate to anything. It could be some infrastructure about when you have a backup plan. Where does the core supply sit? Is it distributed? Is it local? Does it work better in certain situations to be distributed or local, depending on if you're in a rural place or somewhere else? But these things should be able to be codified in some knowledge management system if people not only just talked about whether they were successful, but what did they learn that other people should not or should do, and in what context was that gained?
Excellent. Thank you for that, Dr. Juan. Dr. Newland.
Thanks, Francisco. I feel like when I think about antimicrobial resistance and internationally, the things that pop to my mind, obviously in pediatrics, is neonatal sepsis with Klebsiella pneumoniae that are resistant to carbapenems. We know that even in this country that when we have people travel and they come back, that they're at that risk, and we might see that. But the other one that I don't ever think about, but is the largest killer in the world from a bacterial resistance, is tuberculosis. And how do we, in our collaborative efforts, make sure we continue to improve upon prevention and help elsewhere so it doesn't end up here? We have great infrastructure, but we don't talk about it. But it's the greatest killer. And I think we have to continue to partner to do that. And I struggle. I just read Everything's Tuberculosis, and I've been profoundly touched, even to continue to think, how do we collaborate to make sure that we're addressing that, because it's right here too, and we just don't talk about it because it's not as prevalent as other things.
That is very true. Thanks for that, Jason. I wonder if there's other thoughts in terms of tuberculosis, and I will throw in another one. If you talk about pediatrics, of course, diarrheal diseases, not in the United States, but in the LMIC countries, very little data on that aspect. Dr. Abdul Mutakabar?
Yes, thank you so much. To Dr. Newland's point about TB, I think that, I would like to reemphasize, someone else talked about working with LMICs. A lot of our work that we do, I feel it really hinges a lot with collaboration with higher income countries, likely because they do have that robust infrastructure to communicate, to talk about the things that they're doing and facilitate that convo. So when we think about things like TB, it may be because, we have folks that are coming from LMICs and we aren't able to have that facilitation of that conversation to talk about why it exists. I think one thing that I think about too, just with the propagation of ESBLs or even CRE, a lot of times it will start from lower income countries, when we think about war-torn countries, and then that bacteria now coming back over. One thing for me that's been very helpful is to start gathering insights on maybe places people have traveled and so on. So really integrating all of those disciplines into that conversation. So I'm a PharmD. So on that team, we have the PharmDs, we have the PhDs, we have the MDs and so on. And we have that convo about where people may be coming from. Then that directs the therapies that we consider using first. So I know that, in an LMIC, they might deploy colistin or some other therapy. So what's last line in the United States, that might not be last line, in those countries. And now, that my last line is no longer my last line. I have to consider how I integrate treatment therapies and so forth. And so I sum all this up saying that we do need, more firm communication strategies with LMICs, perhaps opportunities for publication, perhaps opportunities to support them. It may be what I've noticed as a journal editor is there may be like language differences in different ways, as Dr. Wong said, the way that we describe, the approaches that we use in our studies. So maybe making that more a more open option for those folks so that we can have that data to our disposal, and that we, as individuals providing care in the US, can account for these very different things, because as Dr. Patel said, microbes don't have borders. So we have to start really thinking about those pathogens that folks can be exposed to. But I say all that about TB as it likely is because we do see that increased propagation in LMICs.
Thank you, Dr. Jam. I think we have covered quite a bit on the first two, international dimensions and international AMR capabilities. I don't think we have heard a lot about accountability structures to ensure sustained progress and indicators of efforts that will be especially useful to track. So I wonder if you could comment on those two aspects. Dr. Patel.
Yeah, I'll try to take a stab at the third. I believe that this question hasn't been answered because it's almost an impossible question to answer. We know that in antimicrobial resistance, we have strong, strong things that we can measure, but sometimes it's hard to understand the implementation of something and how it relates to the outcome. As I was thinking about this third question and the topic of tuberculosis and something that is so cross-cutting across infection prevention and diagnostics, as well as use of antimicrobials. Something that I thought about for the third question is really improving public reporting of how much money have we invested into AMR research from the different agencies. I think that in the past we've talked about and there has been basic research and development in infectious disease and AMR, but I think that we could really talk a little bit more, like where is the money going and what is being supported. We've heard a little bit from others about implementation work, and I think that could potentially be a metric in looking at how exactly we're investing into AMR from all sorts of aspects, whether it's research or something else. That is potentially a reportable kind of metric that, again, would be important at the US level, but as well as internationally.
Excellent comment. That's something I have not thought about. I wonder if I could take a little bit of moderator's benefit here and talk in terms of what things to track that measure success. Of course, there is the funding component, but also what metrics we take in terms of what actually resistance is. I think it was brought up in the first session. Our friends in the European Union tend to emphasize resistant and indicator bacteria when it comes to the environment and food continuum, right? E. coli with certain resistance, generic E. coli. In our side of the world, we tend to focus more on pathogens. That creates a big divergence in how we understand success. I wonder if the committee has some comments to that end. And I was just reminded we have 5 minutes, so we got still plenty of time to discuss this. Dr. Jenkins.
Thanks. Just to kind of address that third point, I think governance structures are really important concept and one that isn't naturally embedded in many healthcare systems. So just making sure that the tests that are being carried out are actually giving you the results that you expect is really important. Quality assurance schemes are really fundamental to good microbiology laboratory capacity. And I think having a focus on that internationally would certainly reinforce the reliability of the results that are being produced. And you can't automatically assume that the results coming out of a laboratory are actually accurate. There are some, for example, the CESAR program in Eastern Europe and Central Asian areas. It was one study looking at antimicrobial susceptibility tests. They realized that the susceptibility discs were not working well because they weren't designed for particular climatic conditions common in certain areas, particularly in the global south. And even if you've got those discs, the issues around consumable logistics is a real. I've been in a laboratory where the susceptibility discs were 5 years out of date. So if they're not working, it looks like everything's fine. There's no resistance. But in reality, you can't rely on those results. So I think developing good quality assurance schemes as part of any international efforts is essential. Stop there.
Thank you, Dr. Jenkins. I don't see any hands up, and we have a couple of minutes left. Dr. Patel, please.
Well, I'll take the bait. I think there aren't hands up because this is a really difficult area, right? So it would be lovely if this task force could say, well, the accountability structure is the goal is to eliminate AMR, and you're successful when it's gone. That is not going to happen. There's no way. I don't think anyone on this call believes that's the case. And so what you're doing is you're really preventing something from progressing at the rate that it will progress without your intervention. And again, that's like hard to understand. One of the things that I've learned working with the ARLG is I think we need to value not using antibiotics or using shorter courses of antibiotics or using less broad spectrum antibiotics as something that in our space, perhaps it could be framed in a patient safety context or a community or country safety context, like using fewer antibiotics in a safe way is a good thing. And maybe that plays out in animals as well. But these are just, they're hard metrics to really throw out there and say, you should be accountable to do this. But I think this is all of our responsibility to think about what we can measure as outcomes and what are the types of outcomes we want. I mean, we want to be able to treat our patients to make them better or to prevent them from getting sick with using the least narrow spectrum antibiotics needed or no antibiotics when they're not needed, but also getting those patients who might need, more advanced treatment in an expeditious way so they get better. But these are just really hard issues to frame because there are so many factors at play. And I think that's why no one's saying anything. But maybe the challenge to the CARB task force is to think about, what are the criteria for success that you'd like to measure here. And we don't have all the answers, but I think we do need to reframe some of what we're looking at to think about if we looked back on what we did 10 years from now, 20 years from now, what would we say was the right thing to have done? And then, how can we flip that around and say that's what we should be accountable for doing now?
Thanks for that insightful comment, Dr. Fatal. Indeed, it's an enormous task. I think we are just at the minute, so I would like to thank you all, fellow council members, for your insightful input on Goal 5. And with that, I will just turn it over to Paul and Jason to close us out.
Yeah, thank you, Francisco. Jason, I'm going to toss it to you first, and then I'll finish this up.
I just want to thank everyone for a great day. I think we're in a great position. We know that the recent budget has increased in funding for AMR, so we appreciate that. And I think we need to just keep our efforts moving forward. And so thank you. I look forward to our next meeting together.
Thank you, Jason. I echo Jason's appreciation. As we spent the last 3 hours thinking about what the National Action Plan looks like moving forward, we've also somewhat reflected over the last 10 years of a National Action Plan, 2 National Action Plans. And, I want to commend the agencies for, really a lot of those goals and objectives, or the objectives specifically that were laid out in that first action plan, and subsequent ones have progressed and are mainstay now, and we certainly continue to need to work on that. But I really appreciate this council's thoughtful input on these questions as we think about what do the next 5 years in the National Action Plan look like, and how do we continue to push collectively deeper into those goals and push to action, more mid and long-term impacts on this continuing to evolve issue that is, as we've finished up talking about here, is so big it's hard to put really what does accountability structures look like there. I want to thank our PACCARB staff and everybody involved for helping to coordinate. A lot of work went on behind the scenes, doing conflicts of interest, doing setting up this virtual meeting, doing all of the various activities. So thank you to the staff and HHS Live for assisting us in that process. I want to thank the PACCARB members for the thoughtful responses. I know we've gone 3 hours here without a break, and everybody's probably ready to go get a drink and a snack. But thank you for staying engaged. Your comments have been thoughtful. They've been helpful, and I encourage the CARB Task Force and RGEs that are here to take these comments back, as well as those from public comments. And as we close out, thank you to Pael and Lynn and Francisco for helping me and Jason to moderate these sections. And finally, those of you watching out in virtual land, remember that our our comment period is open, I believe, through the end of the week. And so information is available on the meeting website as to how to submit those public comments. But I would encourage you to, not only give broad input, but also if there's any of these questions that were raised today that you wish to provide further impact or input on, those will be passed along to both the PACCARB and the CARB Task Force. With that, again, final thank yous. We look forward to meeting again, and I wish everybody a wonderful afternoon. Thank you.
Produced by the U.S. Department of Health and Human Services.